And I now declare open this public hearing being held at Mantra on Russell of the House Standing Committee on Health, Aged Care and Sport, for the inquiry into the health impacts of alcohol and other drugs in Australia. In accordance with the committee's resolution of the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published on the Parliament's website. I wish to acknowledge the traditional custodians on whose land we meet and pay my respect to the elders, past and present, of all Australia's Indigenous peoples. I now welcome Dr Elizabeth Moore, the President of the Royal Australian and New Zealand College of Psychiatrists, to give evidence. For the Hansard record, before speaking, would you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to give a short opening statement before we proceed to discussion. Thank you very, very much for travelling to Melbourne for this.
Thank you, Dr Freelander. I'm Elizabeth Moore. I'm representing the Royal Australian and New Zealand College of Psychiatrists as their President. So on behalf of the Royal Australian and New Zealand College of Psychiatrists, I'd like to acknowledge the Wurundjeri people and pay our respects to elders past, present and emerging. The College also recognises those with a lived and living experience of a mental health condition and affirms their ongoing contribution to all the work that they do. In this, we also acknowledge college members, college staff and the community as people with lived experience. Thank you for the opportunity to attend the hearing. A little bit about the college, the RENZCP. It's a membership organisation and is responsible for training, educating and representing psychiatrists in Australia and New Zealand. It has over 8,500 members, closer to 9,000, including 5,800 qualified psychiatrists and over 2,000 trainees. The health impacts of alcohol, nicotine and other drugs in Australia are profound. We recognise their impact not only on the individual, but also on families, carers and communities. Psychiatrists play a key role in diagnosing and treating individuals experiencing alcohol-related harm, substance use disorders and related mental health issues. And the College recently made a submission to this inquiry, which I'm happy to answer questions on today. The College notes that the current AOD services do not adequately address substance use disorders as a mental health condition, and this leads to fragmented care, particularly in rural areas and among Aboriginal and Torres Strait Islander communities. For individuals experiencing substance use disorders alongside a comorbid mental health condition, they are likely to receive less effective management and treatment, as services are often ill-equipped to support individuals with complex presentations. Another factor impacting the delivery of AOD services in Australia is the considerable variation across jurisdictions, which is currently not equitable regarding geographical reach or the targeting of need. This means that some Australians can access services when they need them, but many more are missing out due to their location. Critically, AOD services generally remain detached from the rest of health, including primary care, mental health and emergency departments, and there is significant overlap but limited interaction between the services. So, as psychiatrists, we are, of course, medical doctors who are part of the mental health workforce and can diagnose substance use disorders alongside comorbid mental health conditions. Investment in upskilling the workforce to be responsive to AOD as a mental health condition and in stigma reduction, we feel, is crucial to encouraging help-seeking behaviours. Current limitations include the training of new health professionals, the upskilling of the existing workforce, because of the stigma associated with alcohol and other drug issues. We recognise the rural areas have worse outcomes for individuals with drug and alcohol related problems, as well as co-occurring mental health issues. And we also recognise that the importance of addressing workforce and integrating culturally, and that's integrating cultural competency and responsiveness, particularly for Aboriginal and Torres Strait Islander communities as a priority population who are known to experience more harm from alcohol, nicotine and other drug use. We have in our submission called for the integration of AOD services with mental health care, expanded training and efforts to reduce stigma, especially in rural regions where access is limited. We support it being integrated with healthcare to effectively address the complexities of substance use. And also, alcohol is also known to increase the risks of other health-related conditions as well as mental health. And actually looking at those co-occurring conditions is essential. Investment in culturally responsive care, particularly for First Nations people, is critical to the disproportionate harm that they face. We recognise the important role of sectors beyond the health system, and this includes looking at the continuum of care from health promotion, prevention, early intervention, treatment and recovery, at reducing advertising, prohibiting promotions at specific events, as well as engaging family, friends and carers and the wider community in supporting recovery. I thank the committee for allowing the college the opportunity to provide evidence at this hearing, and happy to have a conversation.
Good. Thank you very much. Sorry. I might start with you, Michelle, if you have any questions.
Thank you, Dr. Moore, for your opening statement. I just want to draw you out, I guess, on workforce and the role of specialist psychiatrists. Now, the psychiatrists, as you mentioned, there's only 5,800 thereabouts around the country, so they're few and far between. They are stretched, and I do wonder what it would take, what levers we could pull to enable them to incentivise teaching and training of other health professionals such as GPs, nurses, nurse practitioners, community caseworkers, so that we upskill and uplift the workforce more broadly. And I'm really, I guess, focusing on the psychiatrists with experience. I think they're the ones who have the greatest contribution to make with respect to workforce uplift. Could you share some thoughts on what we can do as a federal government in incentivising training? Because as you know, teaching doesn't pay in the way clinical practice does. So what kind of levers would it take to make that an effective incentiviser?
So a very good question. There are a number of things at the moment that are available. The Mental Health Professionals Network, I think, could be one area the federal government could look at in terms of increasing the amount of support to that network.
What do they do? Could you clarify?
They are a non-government agency that actually promotes mental health training and education across multidisciplinary teams. They have various communities of practice. I'm a member of the military and veterans one, the eating disorders one, the alcohol and drugs one. Perhaps we could increase that and make that training more available. Certainly certification, I think, is important as a lever to get people to increase their amount of training in alcohol and other drugs, and incentivisation then in the clinical space for dealing with complex issues. General practice, our general practice colleagues certainly have said that they are very keen to be able to talk about patients and be incentivised to do that, but not necessarily with the patient there. So looking at some of the Medicare item numbers where they can get advice from a psychiatrist without necessarily having the patient there who may not be available at that time.
Like case conferencing?
Yes.
Right. Yeah. Thank you.
Good. I very rarely didn't get people to introduce themselves at the beginning of the session, so perhaps if we could start from...
Sorry. Dr. Michelle Anandaraja, member for Higgins.
Jodie Ballier, member for Dunkley.
Mike Freelander, member for Macarthur and chair of the committee.
Anne Stanley, member for Warrawa.
And online,
It's Julian Lisa.
welcome Julian. Anyone else online? No? Good. Thanks, Michelle. Jodie, do you have some...
So thank you, Elizabeth. You talked about the sector doesn't address AOD as a mental health issue, and I suppose that's probably a very big question or comment. What do you think's missing that we need to be thinking about?
When you think of substance disorders, and I'm putting nicotine in there as well, it's really important to actually understand why people are using to excess. So alcohol itself, in Australia and New Zealand, there is an alcohol culture, unfortunately. Although I do see some changes in our younger generation in some areas. Many more younger people are choosing not to drink or to limit their alcohol. I think the issue in the past has been that there has been a divide between alcohol and drug issues and mental health issues. But we actually know that the overlap between the two is enormous. And so if you come through the alcohol and drug sector, there should be an understanding of the mental health issues. If you come through the mental health sector, there is an understanding of the alcohol and drug issues. So it comes back to that person-centred care. And the division that we've had with the funding streams of either going down the alcohol and drug path or the mental health path has perhaps not been the most person-centred that we could be. Where that comes together is sometimes where you have co-located alcohol and drug services and mental health services, or very good links. And during COVID, we certainly found that that was one of the things that actually improved, certainly in the ACT, where I'm from, that there was more integration or more collaboration between the drug and alcohol sector and the mental health sector to actually help our most vulnerable. So I think perhaps what we need is models of care, and really if you think of a Venn diagram, there are people that have mostly alcohol and drug issues and some underlying, obviously, psychological issues to create that situation. You have people with mental health conditions who may not have any substance use issues, but there is a huge lot in the middle that overlap that have both. And maybe our model of care is to actually look at who needs, the person themselves, who needs what care, and a more care coordination model to best meet the person's need.
What are the implications for not having that? Like, loosely, I'm sure there's lots of implications, but what would you say are the biggest issues? Because when we don't have that person-centred care.
The biggest issue that we see is that people in the alcohol and drug sector perhaps are not getting their mental health issues fully addressed. And people in the mental health sphere are not getting the underlying drug and alcohol issues correctly addressed. And that means not only a whole of person approach, a person-centred approach, but also the family and the community. So what supports do we need to put in place around all of them so that the community can support the person and the family can support the person?
Thank you.
Good. Thanks, Jay. Julian, do you have any questions?
Yes, look, I was wondering a little bit if you might speak about the evidence, to the extent that it's available, about addiction, particularly to cannabis, and the psychological effects of cannabis addiction more broadly, and any other types of drugs that you want to particularly touch on that are presenting stronger challenges for you as psychiatrists. So is that question clear, or do you want me to restate it?
So if I could rephrase, so it's some thoughts around cannabis use particularly, and also any other areas that are causing us concern at the moment.
Yeah, I suppose I wanted particularly to focus on cannabis, but also if there are other drugs that are the cause of particular psychoses that are presenting themselves to you regularly, that are a cause of real concern for Australian psychiatrists.
So certainly with the cannabis use disorders, there are some people that can use cannabis on a recreational basis with no harm. If there is an underlying vulnerability to a mental health condition, then we do see cannabis as one of the precursors to psychosis. And certainly if you have a person with psychosis and they use cannabis, it can increase the frequency of their presentations to hospital and a worsening of their symptoms. The medical use of cannabis is a cause of concern to us, and we have put together some media around that. There is very little evidence for the use of medical cannabis for most conditions. However, it is available in Australia. The problem is the quality of the cannabis and how it is being sold, the quantities that are being able to be accessed, and the subsequent increase in emergency department presentations that have been reported, especially in Queensland, but across Australia and more broadly. In terms of other drugs that cause psychosis or have been associated with psychosis, the psychoactive substances certainly are a cause of concern to us. Yeah.
To restate that, so you're definitely getting comments from your colleagues that there are increased presentations
To emergency department, yes. There's certainly, if you look back through the media, about 3 months ago, certainly from our Queensland branch, and there are many cannabis farms up there, there was a definite spike in presentations to emergency departments with psychotic illnesses. And it appeared to be related to the consumption of cannabis. The cannabis, and we have talked to the TGA about the regulation of medicinal cannabis.
So was it related to the prescription of medicinal cannabis, can you say?
The consumption of it. So the prescription itself may be for a condition for which it can be prescribed.
Sure.
But as I said, the evidence is not very clear for the use of cannabis in most medical conditions. I think intraocular pressure is about the only one. Pain, yes, maybe in some people, but there are other ways of dealing with pain conditions.
Yeah. Sorry to interrupt, Julie.
And then there are the usual psychoactive substances that are used illicitly that we know from the literature can cause psychosis, which is why we call for a continuum of care approach. We really need to address the awareness of that this could occur. We need to look at restrictive elements, health promotion in other ways, so people can look at other ways of improving their well-being, and then making sure we can get early intervention as well.
For the record, could you list some of those drugs?
So the psychoactive drugs, so things like LSD,
What about things like amphetamines?
and amphetamines, yes.
Cocaine?
Cocaine, again, is one of those substances some people can take without evidence of harm on a recreational basis, although we do not promote it. But yes, cocaine in a vulnerable person can cause issues.
Good.
Yeah.
Julian?
Oh, that's fine. That's a good summary. Thank you.
Good. Ms. Stanley?
I've got a few. Sorry. You made the comment in your presentation to begin with that younger people are not choosing alcohol as much, but are they substituting what in other generations was alcohol consumption with other drugs?
I actually don't have any evidence, Ms. Stanley, I'm sorry. You can postulate, but it's certainly I would have to take that on notice and see if I can find some research for you.
The reason for my question is there seems to be a lot, particularly with sporting people at the moment, who don't seem to be being concerned about alcohol, but there are a number of drugs-related incidences which are far more prevalent than they have been in previous years. And I wondered, is that going to flow through to our young people? Is actually it? Because, those sort of things often do. And, it's great that people are not choosing alcohol, but if they're substituting it with something else, we still haven't fixed the root cause, is all. If I was a family member or a person who has recognised that my use of whatever substance, alcohol or other drugs, is a problem, right now, how would I go about finding support? So I've come to the point where I've realised that I need help. Mm-hmm. And how long, in your view, will that take? Both, I'm assuming there would be differences between the city and regional, but I just wondered if you would be able to talk us through that.
So there would be a number of different pathways, and it depends on the level of psychological distress that you are currently feeling. Certainly, e-mental health prac is a government organised mental health website that has a lot of information on it, and we find that many people don't want to talk to somebody. First off, they want to find more about what the condition is and what they can do for themselves. If you were wanting to speak to somebody immediately in psychological distress, there would be the various hotlines in all of the different states and territories. Or there is a number of drug and alcohol bodies, consumer bodies, that you may feel more comfortable at going to. I do not have any advice on wait times. I think that's something the jurisdictions would be better able to help you with, either for mental health services or for drug and alcohol. So really on your presentation, and if it was your family member ringing, presumably the different levels of inquiry. So if it was a general inquiry, better answered by one of the consumer bodies, that would be good. In rural areas, again, speaking to your GP is always a good option. And then the use of telehealth in the rural areas certainly has decreased the wait time there to actually get a psychiatric appointment.
Apart from alcohol and drug related, what does the college consider wait times are for its services? So I go to a GP today and the GP determines, for whatever reason, doesn't have to be that I need to see a psychiatrist for a better determination of what I've got. What does your college have a view about how long that process might take? And if it is a long time how we fix it.
So just to be clear, the college is the member organisation. It doesn't offer the services.
No, but you have members
That's
who
it.
are psychiatrists
Yep.
who are dealing every day with people who want appointments as soon as they can get them and can't. So they clearly would have a view about what support they would like to provide the service to their patients they can.
Yes. So in terms of wait times, that is again the level of psychological distress. And we have put submissions in to say we are actually in crisis mode in Australia. So if you're very psychologically distressed, yes, you'll get to see somebody. If you're not so psychologically distressed, then you wait and you wait. And certainly the decreased number of private hospital beds available has made an impact, I think, on our public services. So we've had private hospitals close because of the funding structure, is my understanding, and this has made us less available to treat some patients that would have previously gone privately.
So you're talking about private hospital mental health services?
Yes.
Right.
Yes.
Yeah.
The what would help whilst waiting for a specialist, and specialist wait time does vary across Australia and between rural and metro significantly. What would assist certainly us is something similar to that which we put in the ACT, which is if I could digress just a little bit. So MindMap in the ACT is an online service for children and young people. It's basically got a front end which has a lot of information, but it is also backed by clinical navigators and non-clinical navigators. And there is the ability there to support a young person for a period of time when they've been accepted for a service, but they're on the wait list. So something similar would be incredibly useful for some of our services. So they're not offering a clinical service in that time, but what we have heard from people is that they feel supported, their levels of distress go down, and they know that they are going to get into the service.
Does the college publish any data around wait times or anything that you could supply the committee on notice?
Because psychiatrists, we only have anecdotal data from surveys which are not complete.
Sure.
And again, the jurisdictions would be the best place to actually seek that.
Sure. Thank you very much for that. Your comment about, your comment about medical cannabis has me a little concerned because we are often told as legislators that this is a good idea, that these conditions, I don't have a health background, so I am taking people at their word. So is it because I am given a prescription for medical cannabis and the actual drug is not being produced at the efficacy that it is being just prescribed at, so it has a much high THC or whatever the active ingredient is than the doctor thinks is necessary, and it's not the patient's fault and it's not the doctor's fault, but it is a problem of the production? Or is it people who are being prescribed medical cannabis get such benefit from it, they think just a couple more will make me feel so much better? Because often when people take drugs, because it makes them feel better, they think if they take another one it'll make them feel a lot better, like heart condition or any sort of condition can elicit that, not just this. So is that what is going on, or we don't know and we need to figure it out? Or
we understand that the quality of the medicinal cannabis is not as it should be. So it's not regulated, and there is variation in the quantities of THC within the medicinal cannabis.
And are you aware of anything that is being done to address this concern, or is this new?
We have raised it to the TGA,
Yep.
and the TGA is certainly looking at
Sure.
it. Yeah.
Thank you. Thank you very much.
Good. Yeah, thanks very much. I've got a few questions. My first question is, why should the psychiatrist be running drug and alcohol policy, and do we have the wrong model? Because in my electorate, in my hospital, what happens is, first of all, we often don't get a proper history of drug and alcohol use. And so it often flies under the radar. But secondly, if people are seen as having a drug and alcohol, or as you know, it's often polypharmacy involved, they are referred to a non-government organisation for the management because our acute mental health services don't deal with it. It's referred to Odyssey House or one of the other non-government organisations. And many of our public psychiatrists and registrars feel they're not trained or given the resources to deal with drug and alcohol problems. So do we fundamentally have the wrong model?
I think there is a role for both. As I talked about that model of care that actually looked at those three parts, it isn't... The issue that we need, I think, is to emphasise the whole of person care. If you have a system in crisis, as we do with our mental health services, then there is obviously an emphasis to look at those people with complex mental health needs.
Sure.
What we need, I think, is that more coordination between the drug and alcohol services and mental health services. As I talked before, the levers around ensuring that there is the ability to have that complex care coordination.
And who should do that?
Ideally, that should be specialist care. So we have specialist drug and alcohol clinicians, and
They're pretty few and far between.
and that's why we've asked for the increased levers to increase training in that, and to ensure that actually there is, I think, better training in terms of other health professionals as well to be able to pick this up.
I'm not sure if you're aware of the Orange Door model in Victoria, which is around supporting domestic and family violence, and they've got like an intake and triage type model with co-located agencies. Would a model, that model that triages people to a range of service where you've got that whole of centred person, is that what you're thinking? Do you have a...
That would be ideal. Logistically, it's difficult with the infrastructure. So whether or not we can be smarter and actually use the ability to get the teams together over Zoom or one of the video conferencing apps, that certainly would help in terms of rural and remote. Again, incentivising that in terms of activity-based funding and in terms of Medicare item numbers.
Right, just going back to that a little bit. It seems to me that drug and alcohol abuse is a very complex issue, and yes, there are elements that may relate to mental health, evidence, or there is obviously issues related to liver disease with alcohol, neurological disorders with some of the other drugs. Don't we need a multidisciplinary approach?
Yes.
Rather than just if I can put it, a psychiatric approach?
Psychiatrists are medical doctors.
I'm aware of that. Yeah.
But you make a very good point. The other point I think people don't understand is alcohol is a non-specific carcinogen, and so it'll increase your rates of all of the common cancers. So as psychiatrists, we also do lay hands on patients, and that's why you actually need that specialist care. But I'm with you, the multidisciplinary approach is what we are advocating for.
Right.
With specialist oversight.
I'll extend that a little bit further. Shouldn't every major public hospital have a drug and alcohol unit with inpatient and outpatient services?
I would rather go for the areas of need. So let's get to location specific. Where are large locations that require drug and alcohol services? We want to treat people in the community rather than actually treat them in a hospital. Hospital itself can be quite a traumatic experience. So if we're looking at different models, then surely what we need to do is decrease the stigma around having a drug and alcohol issue, offer detox in the community, have a complex care plan that involves multidisciplinary teams and with psychiatrist oversight. That would be the best model. So increase some of those very good models that already exist in, I'm thinking here of Canberra again, looking at actually making sure that our community services and treating people in the community is the best that it can be.
Good. Okay. Just a couple of other questions. I want to go back to the medicinal cannabis issue. Is it appropriate that these drugs can be prescribed without a proper physical examination?
We would always encourage a full assessment before prescription of any drug.
Good point. Okay. Thank you. And again, this is a matter of training of psychiatrists. Do you think there is enough evidence or enough effort being put into drug and alcohol management training in the present psychiatry training curriculum?
This is certainly something that we're going back to have a look at, partly as a result of this inquiry as well. It's something that our trainees say that they don't feel some of them are adequately trained in, but it is actually part of the whole of person, so we will go back and look and make sure that there is access.
And are we getting enough people going into psychiatry training?
We are actually oversubscribed for the places that we have. And this is a change from maybe 5-10 years ago. So some of the stigma around psychiatry has also decreased. So we have actually asked the federal government to extend some of our training places. We have a rural pathway. I'm not sure if the committee is aware. The federal government actually gave us some money to develop a rural pathway that is now up and running in Western Australia, and we are extending it to other states as well.
Yeah. And one last question, and you may or may not be able to answer this or may like take it on notice. Are there concerns about some new drugs of abuse that are appearing on the horizon that we should be looking at?
There is always concern about new drugs that are arising, and in fact it changes from month to month. Curtin University used to have a very good think tank that looked at what was on the horizon. So I can't give you any specifics, but I can certainly take that on notice.
Good. And yeah, that would be good if you would mind doing that. Any further questions, Michelle?
Dr. Moore, I just want to ask you a couple of more questions with regards to community-based care. I think that there's absolutely a role for hospital in the home type models, and I just wanted to tease you out, where are we at with home-based care? Because I think I had a conversation a long time ago with the private hospital sector, and they were running some pilots. I haven't seen this rolled out in the public space as much, but where is the state of the art with respect to home-based care?
So certainly there are models around that will do detox within the home, and that is actually preferred if the person and their support system is agreeable to it. Sometimes people just need a rest from the person themselves. The person needs a rest from their family. So it is available. I cannot tell you how available it is, and my feeling from what I've heard from people is it is less available in rural areas.
Do you know who are running home-based detox?
It varies from state to state, and it is usually the non-governments, although there are some government services that do that, especially since COVID.
The other question I had was, you mentioned certification as being an important lever. Can you just elaborate on why that's important for workforce?
I think actually having a certificate in drug and alcohol is an important lever if it's associated with an MBS benefit. So the two go together. People do want to be upskilled in various areas. And actually having a certificate to show that you have done that upskilling and advanced skill training is something that we've found very useful.
Okay. And then finally, just a question on, I guess, drug treatment, right? The drugs we have are not great. Camprosat, methadone, these are things that have been around for ages, naltrexone, etc. The GLP-1 agonists are quite exciting. There's a large body of sort of preclinical work looking at these. Where are we at with inhuman studies and sort of phase 3 clinical trials using the GLP-1 drugs?
Again, I'll have to take that on notice. I'll go back to our committee for research.
Okay, thank you.
Good, thank you. Jody, do you have any questions? Julian, do you have any other questions? I guess that's a no. I've got one last question. Does the college have any estimate of the costs of drug and alcohol abuse to the health system?
Not to the health system, but overall, and we do have a position statement which actually was 2016, so we will have to update that. But 12 years ago, the estimations there were that there were 5,504 deaths attributable to alcohol per year, and in New Zealand it was about 600 to 1,000 people die of alcohol-related causes per year. The cost to the community in terms of crime, violence, FASD, was associated at about 5.3 billion a year in New Zealand and up to 15 billion a year in Australia.
Great. Thank you very much. No further questions? Good. Thank you for giving evidence today. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Monday the 11th of November 2024. And you have been asked on notice to provide a couple of things for us. That would be great. You'll be sent a transcript of your evidence and we'll have an opportunity to request corrections to any transcription errors. And once again, thank you very much for giving us your very valuable time today. Thank you. And thank you very much.
Yeah, it was very interesting. Thank you.
welcome witnesses from the Drug and Alcohol Foundation to give evidence today. So, thank you very much for coming on today. And now welcome witnesses from the Drug and Alcohol Foundation. For the Hansard record, before giving evidence, would you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite one of you or more to give a short opening statement before we proceed to discussion.
Thank you.
Thank you.
So, Erin Laylor, CEO of the Alcohol and Drug Foundation. I'd like to just begin by acknowledging the traditional custodians of the land that we're meeting on today, the Wurundjeri people of the Kulin Nation. Pay my respects to elders past, present and emerging, and to thank the committee for holding this very important inquiry. As our submission notes, there are systemic drivers of alcohol and other drug harm in Australia, including social, economic, commercial, health and legal determinants that create vulnerability and increase that risk of harm. This means that responses to minimise harm must be evidence-based and target those systemic drivers. This inquiry has got the opportunity to really significantly shape the direction of AOD policy and governance in Australia. We're nearing the development of the next 10-year National Drug Strategy, and states are developing strategies and holding summits. It's an issue for all governments, and it's vital that we adopt a systemic, coordinated and evidence-based approach. Coordination of responses to AOD across multiple jurisdictions is made more difficult without strong governance structures like the now defunct Ministerial Drug and Alcohol Forum. Governance is important to addressing cross-jurisdictional issues like opioid dependence treatment programs and the new emerging risks of synthetic opioids. Governance and accountability really must be a key focus of this inquiry. Our written submission outlines the significant health, social and economic issues caused by AOD harm in Australia. Now, despite this, some submissions to the inquiry suggest that alcohol consumption and related harms are no longer a concern. However, we know that alcohol continues to be a leading cause of disease, injury and death in Australia, and it causes an estimated $75 billion in social costs annually. Alcohol-induced deaths continue to be at unacceptably high rates, and patterns of risky alcohol use are continuously changing. Most recently, we saw this amongst young women, where we see a narrowing in the gap in risky drinking between 18 to 24-year-old men and women. Alcohol companies are known to be maintaining their profits from those who drink at the riskiest levels, with just 20% of the population consuming 70% of the alcohol sold. Addressing the interests of commercial entities requires policy that put public health outcomes first. We've seen the detrimental effect of commercial interests through widespread alcohol marketing, particularly through social media, where unregulated use of personal data is resulting in targeted harmful advertising, and we're seeing the outcomes of commercial interests in the medicinal cannabis space, with poor regulation and enforcement being exploited by some commercial entities, leading to harm. We need a systemic, strategic and coordinated approach to address the drivers of AOD harm. The treatment system is overwhelmed and reactive responses are not adequate. We cannot continue to park an ambulance at the bottom of the cliff. We must build better fences. This means addressing social determinants of harm, working upstream in primary prevention to strengthen community protective factors and resilience, and provide information and access to support earlier, before risky behaviours have become entrenched. We know there are also opportunities to enhance digital health services and integration with front-end services and systems to improve the experience of people who are seeking help, as well as better support for their families and friends. And we also know that the criminalisation of personal drug use continues to cause harm to individuals who come into contact with the justice system, while they fail to stop all illicit drug use. We face the emerging risks of drugs of concern in the drug supply, like nitazenes and fentanyl, that put people at unexpected risk of harm. And a health response to personal drug use is needed to improve outcomes and prevent further marginalisation of these already experiencing harm. Approaches that prioritise the health and wellbeing of our communities must no longer be driven by stigmatising attitudes. We need a commitment to reduce stigma. including in the way that government policies, campaigns and communications contribute to it. This will mean reforming laws and regulation that fail to protect communities while reinforcing harm and disadvantage, and it will include a balanced investment across all efforts to reduce AOD-related harm, which includes increased efforts in prevention, early intervention and treatment. Thank you.
Thank you. Now, I might just get all our committee members to announce themselves and explain where they're from first, starting with Ms Stanley.
Anne Stanley, I'm the federal member for Werriwa.
Mike Freelander, Chair of the Committee and Member for Macarthur and South West Sydney.
Jodie Ballier, federal member for Dunkley.
Dr. Michelle Nandraja, member for Higgins.
Julian, are you online? No, he's having a rest. I might start with questions of Ms Stanley.
I'm not sure that you were in the room when the last witness gave us some evidence, but one of the things that she suggested was that the alcohol consumption with young people has changed and they are drinking much less. And I've seen those media reports as well. My question to her, and I wondered if you had any experience as well, is has it just gone somewhere else? So are the same amount of young people doing risky behaviour like over using alcohol, are now they choosing a different drug of choice? And does that mean that we need to think in the health space about how we address that? So they've heard the health messages, not a lot of them are smoking now, harder to get vapes, but are they doing something else?
So I'll start by responding to that, and then Rob might introduce himself and add. So I think the first thing to note is that we have seen a reduction in the number of people under the age of 18 who are using alcohol, steady decline over recent years. That pattern is shifting in young girls. So young girls under the age of 18 have actually increased their use of alcohol. It was identified in the last National Drug Strategy Household Survey done by the Institute of Health and Welfare. So they are now, you will find more girls are drinking alcohol than boys. I think the other thing to note is that whilst we've seen a decline in the number or the proportion of young people who are using alcohol, that hasn't correlated to a reduction in harms. So we are still seeing increasing harms in this age group. Now that is probably because those that are drinking a lot more. So stigma is contributing to this. We know that the majority of young people who use alcohol get it from their parents. They drink in the home with alcohol supplied by their parents or by adults from other households. So addressing alcohol, I think many people think alcohol is no longer a problem in young people. It's actually causing more harm than it's ever caused in young people. It's just really targeted on those who are using alcohol. Did you just introduce yourself?
I'm Robert Taylor. I'm the Policy and Engagement Manager at the Alcohol and Drug Foundation. Yeah, just to reinforce what Erin's saying. So we see on the whole a decrease in the number of young people who are consuming alcohol, but there continues to be a cohort who are using in a risky manner and increasing. And so we see in this age group, for example, highest rates of ambulance call-outs, highest rates of alcohol-related hospitalisations. So we know there's a lot of harm that goes on in that group. To your question about substance use in young people, it's actually at an all-time, or relatively all-time low. You look at the kind of 20-year graph for substance use, or illicit substance use for under 18s, and it's been on a significant downwards trajectory for the last 20 years or so. So it's not necessarily as simple as someone replacing one behaviour for another.
But we're seeing in cannabis use in kids as well. So whilst they are the least likely to be using cannabis, they've got very high rates of risky cannabis use. So similar patterns that we see in alcohol.
I was just going to say, which gets down to this question of being really targeted when we're looking at the problem, and something we tried to reinforce through our written submission is that we need to really know who we're talking to and what we're talking about, who the cohorts are, the patterns of their use. You know, we might have these headline numbers that say, oh, substance use is down, but there might be a group, as Erin's mentioned, who are using cannabis in a more risky manner. And so how do we talk to that group?
So if there are less people using alcohol but their outcomes are worse, are they an identifiable group? Are they low socioeconomic? Are they people with other issues, like perhaps mental health issues? Are they particular suburbs or, because, I mean, it seems to me that if that group is getting their alcohol from people, from adults, it's hard for the government to do much more than, because clearly the outlets are not giving it to them if they're actually getting it supplied by our adults. So why are they in situations where that is happening? Is it because of the actual nature of where they live and the other things that are going on in their lives? Do we have that data? Are we able to get that data?
I think there are certainly risk factors for increased risk of harm from alcohol in young people, and we actually flip it and we talk about protective factors. So relationship with their family, engagement with school, engagement with organised extracurricular activities like sport, music, drama, supervised by adults are all really important protective factors that reduce the risk that a young person will experience harm from alcohol and other drugs as a young person and later in life. Socioeconomic determinants, adverse childhood events all contribute, mental health all contribute to that risk profile. But it's not as easy as saying that children in a lower socioeconomic community are the group we need to work with, because we can see young people who are using alcohol at very risky levels across community. There are certain characteristics that go beyond the social determinants. So I think that's one thing. I think the other thing is that there are very significant drivers from a regulatory perspective that change the likelihood that children are likely to use alcohol and to use it at risky levels. And we also know that if a child uses alcohol before they're 18, their risk of longer term harm and dependence is increased. So it's why we've been running a campaign in New South Wales and now in the ACT, which targets parents to get them to understand that teaching your children to drink is actually not in their best interests. You want to keep their future bright by not giving them alcohol, which has been incredibly powerful in terms of changing behaviour for parents. So I think understanding that parents is one part, but we know that exposure to advertising for children, which is targeted advertising, the use of alcohol by influencers, cultural norms of alcohol will all influence a child's likelihood to use alcohol. At the moment in Australia, children are being exposed to alcohol advertising on social media. There's no regulation that stops that from happening. Their data is being sold to alcohol companies so that they can prime them and introduce them to alcohol at an earlier age. We still don't fully understand the impact of zero alcohol brands and the brand extension of alcohol on the use by children, but there's more research happening in that space that suggests that children's exposure to zero alcohol branding when it's a known alcohol brand is actually brand extension and having some effect on their likelihood. So I think there are lots of levers that government can pull to reduce the risk of harm for children from alcohol and other drugs. One of them is regulatory, one of them is by working on that family environment, and the other are the prevention programs that we talk about a lot in our submission, which is looking at place-based approaches that are delivered in community with young people that strengthen those protective factors. Some of them don't even necessarily talk about alcohol and drugs. They just work to reduce the likelihood that children in that community and others will experience harm from AOD.
One last question. What happens when they get to 18?
What do you mean?
Well, it's reduced. You've talked a lot about children and about children under 18. So what happens when the magical day comes and they can do whatever they like? Is there a uptick? Are the less drinking behaviours of underage, are they carrying
Carried
it through for the rest
That's
of their
what we're-
life, or they're not?
We're seeing that change, and we talked about that in our submission and in the opening statement. Young women 18 to 24 have really increased their risky use of alcohol, so not just any use. That's significant amounts of alcohol. We used to see a real difference between 18 to 24-year-old men and women. It's the age of experimentation. It's where we're most likely to see people start to use alcohol and drugs. And that gap between men and women in alcohol use has narrowed significantly. And there is no difference in illicit drug use between those two genders where there used to be. So that downward decline in the under 18 group, which has already started to shift, we're seeing it trend upwards for young girls. By the time they hit 18, there's a lot of work that's being done by industry to get them ready to buy their product, and then very targeted marketing to start to convert them to customers. Would you add anything to that?
I was just going to say, in a very general sense, there are these very clearly established evidence-based factors, like we mentioned, marketing, alcohol exposure, and so on, that affect a young person's trajectory, their drinking trajectory later in life. And so programs that are designed to prevent or delay uptake of alcohol and this drug use, but alcohol in this case, are a really effective way of modifying that trajectory, to the point that actually one of the outcomes I just thought it was worth mentioning in the context of the strategy discussion. One of the outcome measures of the current drug strategy is average age of initiation into alcohol use. So it is a really key core thing to try and modify that trajectory early for those lifespan effects.
But it would seem to me that we're putting off the inevitable rather than actually giving them a reason to say no when they get to 18.
I think there's two.
Do you know what I mean?
Yeah, I do, but I think there's two parts to that. One is the longer we can delay the age of initiation,
Of course.
the longer a child's brain has to develop in a healthy environment. Alcohol affects the developing brain in ways that I think we all understand. So I think that's one part of it. I think the other part of it is that in our submission we talked about this continuum of use, of starting experimental first use, occasional use, problematic use, dependence. Our goal as a prevention organisation is to keep people at the left-hand side of the continuum, to not see them progress to dependence and problematic harmful use. The earlier someone starts alcohol under the age of 18, the greater the risk that they will end up with alcohol dependence problems later in life. So it's delaying the inevitable versus reducing the harm that someone experiences from alcohol across their lifespan. And we also know, we do a lot of work with communities through our local drug action team program, which is funded by the federal government. And they will choose different age groups to work with, and our approach with every age group is different. So in some instances, we will work very differently with the 18 to 24-year-olds than we will with the under 18s or the 35-year-olds or the 50-year-olds. So I think it's at every stage, you have to be using very targeted age-specific, gender-specific, motivational use-specific strategies to attempt to reduce the harm, knowing that the regulatory environment is one of the most powerful levers we can pull.
Okay, thank you.
Mr. Lisa.
It's gone.
Jodie.
I'm interested in the young girls and the psychology of why they're that particular group of young women, 18 to 24, there's an uptake in their usage. And I'm also very aware that women over a certain age, I think it's 50, or also there's an increase in consumption and addiction. Do you understand? I understand the social demographics, the marketing and all the rest of it, but do you have a sense of why young women are moving?
I think you've talked about the marketing component of it, so critical. I mean, you think back 20 years ago, the notion of pink drinks and glasses of wine, the way that alcohol's been marketed, it's I would say marketing 101 is to know the gaps in your audience and create campaigns that create new audiences. So there's been a real push, and we saw that during COVID as well, a real push on marketing alcohol to women. We don't fully understand it. We've been talking to government about the need to do more exploratory work to understand the drivers of our increased alcohol and illicit drug use. So it's not just alcohol, so it can't just be marketing. There's something that's changing and we're not fully aware of it, of what that is. It could be more disposable income, it could be increased risk-taking behaviours within that demographic, it could be a response to COVID, there could be lots of reasons. We also know that there won't be a single reason, that within any group, and we saw this in vaping particularly, that people choose to use a substance for different reasons. Some of them will use it a lot, some will use it socially, some will use it when they're stressed. There are different reasons that a substance will be chosen, and we really need to understand that in the 18 to 24-year-old female group to get at how we communicate with them about reducing their risk.
There's one sort of related question. Is there any interconnection between domestic family violence, bullying, those sorts of experiences with alcohol abuse for young women, young men, women and men, I suppose?
Yeah. Look, I think the recent conversation around family domestic violence, National Cabinet, the Rapid Review have all pointed to the undeniable link between alcohol and domestic violence, not a cause, but it certainly increases severity and frequency of domestic violence and violence against women and children. We've seen some outcomes of policy and regulatory change that show that when you introduce regulation, you reduce rates of family domestic violence and out-of-home protection orders for children. So an example of that is the minimum unit price introduced into the Northern Territory, a very powerful intervention that kept children and women safer from alcohol. We also saw trading hours go the other way in New South Wales. When trading hours were increased, we saw an increase in family domestic violence. So I think now Australia is actually having a conversation about the relationship, such an important conversation to have. Recommendations from the Rapid Review were clear around the need to tackle alcohol and its contribution to family domestic violence, and the evidence is clear that we can do things that will reduce that impact on women and children in our community.
I have a couple of questions. So with regards to children, specifically girls, it sounds like they are primed by the industry so that by the time they reach the upper teens and 18, they're drinking and drinking in a risky fashion. Would that be a fair summary?
And I would add primed by our cultural norms around alcohol as well.
So the cultural milieu,
which is partly
plus the industry. Pushing advertising. So one lever would be to ban advertising to children, correct?
Correct.
Yeah, okay.
And the use of children's data to target them specifically with alcohol related.
So what does that mean? Can you just elaborate?
So at the moment, the algorithms on social media
Yep.
collect a lot of information about your preferences. That data is then sold to commercial entities who use that to inform their marketing campaigns. There have been a number of reviews that have recommended limiting the use of children's data for that purpose, with no concrete recommendations at this point in time that would see harmful industries like the alcohol industry being able to access children's data, and we would argue anyone's data. The most vulnerable people at risk of alcohol will also have their data sold, and it's very hard to stop using alcohol in a problematic way when your social media is bombarded with advertisements for alcohol.
Yeah, I guess the question is why does any industry need children's data? Full stop, right?
Yes.
That should just be a no-go zone. No
Yep.
one should be touching that data. The other question relates to, I guess, the availability of alcohol. You can buy it at the supermarket. You can even drive through and pick up alcohol. Talk to us a little bit about online sales. Is that happening? Can you click and have alcohol delivered to your home?
You can.
Yes, it's
Quickly, within 30 minutes.
Dr. Freelander.
happy for you to step in, Mike. That's Hi. This is a huge issue, that you've raised. We have a licensing system for alcohol that was structured. It's been developed over the last 50, 60 years, and it's been structured around brick and mortar premises, on and off premise licenses. But we now have a method of access and availability that undermines all of that. You can get something delivered in 30 minutes. The delivery drivers are not necessarily RSA trained. It's really complicated as to who's liable. Is it the delivery company, the driver? Often there's a bottle shop whose license is actually being used by the DoorDash or the Uber Eats or so on. It's not actually their own license. So the governance is very complicated. We've seen research suggesting that people are using online delivery to extend drinking sessions when they're intoxicated. These are all things that we've set up a system that puts in place certain barriers to accessing alcohol that are designed to manage the supply in our community, and this kind of fundamentally alters that, and it sidesteps the policy framework that we've built over a number of decades. And each state is currently just about in a process trying to figure this out and trying to catch up. But we have very powerful, industry players who have their voice and who want to influence the policy process in a particular manner, and that's of a concern for us. So we advocate quite strongly across the different jurisdictions for things like introducing a 2-hour safety pause, so alcohol's not delivered within 30 minutes, where the risk of extending a drinking session and heightening risks of intoxication, heightening risks of incidents in the home like domestic sexual family violence aren't increased. Cut-off times of 10 a.m. and 10 p.m. for deliveries. Reforms around the use of data, ensuring that delivery companies have their own specific license class so we can actually track. The regulators in many of the states don't know who's delivering because of the way the systems are set up currently. We don't know how much is being delivered, we don't know who's delivering, we don't know where it's going, we don't know who's being refused, we don't know what the refusals are like.
How many years has this been going on for?
It really took off in COVID. And I think there's a difference between the next day delivery, which has been happening for a long time, ordering wine or beer to be delivered to your door from over a week or a day, versus the rapid delivery, which is the business model.
So it's a relatively recent marketing
within the
development.
least 6 or 7 years.
Okay, which means we could roll it back if we needed to. It's not totally entrenched in the psyche.
I mean, you used to go to a bottle shop to get your alcohol. Now every phone is a bottle shop.
Yeah, and you're right. I mean, this does completely sidestep all the guardrails, right? ID, your level of inebriation, your state of mind, etc., etc. So many ways to sidestep. The other question then relates to the Ministerial Drug and Alcohol Forum that you alluded to earlier. I would have thought that this would be a good venue to talk about or socialise these kinds of issues. What was this forum? What happened to it?
So the Ministerial MDAF, Ministerial Drug and Alcohol Forum, was discontinued when COAG changed to National Cabinet. So it used to bring together federal and state ministers from health and police who would, they basically were guided by the National Drug Strategy, and they talked about these cross-jurisdictional issues. And it ceased to operate when, what was that, 2020, when COAG was discontinued, National Cabinet established. What that means we've lost is a mechanism for senior decision makers and policy thinkers to come together to talk about the issues that actually are, and AOD is one of the most, I would say, impacted health issues through our federated structure. It's health systems, it's the justice systems, it's the decisions around responses to personal drug possession that are made often by state governments, and the federal government's ability to influence that is removed. And yet no one's bringing these levels of government together to talk about what would be a national response to tackle alcohol and drug, whether it's alcohol regulation, better regulation of medicinal cannabis, delivery of the opioid dependent treatment program. It was a great step forward to have methadone and buprenorphine put onto the PBS and to be able to be delivered to people who needed that as a treatment. But implementation of it was very, very challenging. Nitazines are now entering our drug supply. They don't enter one jurisdiction, they enter them all.
Yeah.
And so getting better early warning systems that communicate across jurisdictions, better responses nationally are all things that we really, I mean, it is one of the greatest losses to the sector. It's been, you will hear from others
Yeah.
around the need to re-establish a governance structure.
Can I add to that? Incorporated in that was the governance of the drug strategy. And so that's been, because the drug strategy is a shared ownership between all the jurisdictions, that coordination was lost, and so the drug strategy has not been, we name this in our submission, but it wasn't evaluated. It was meant to have a kind of check-in every 2 years, piece of work done, that stopped being done. It was meant to have a midpoint evaluation, that wasn't done. So it was actually not a bad document. We're quite happy with the existing drug strategy, but there was no kind of ownership or sustained implementation. So I think that's a really strong lesson for the development of the next strategy. Whatever governance is put in place, it needs to be committed to, and needs to be, there needs to be strong implementation.
I think it's interesting that this oversight body was disbanded in 2020, and then we've seen this explosion of online sales, risky drinking in children. You know, these things are starting, problems are coming home to roost. Two more questions, just on a front door. So a parent has a child with risky drinking behaviour, or a young person is acknowledging that they have a problem. Where do they go? So I guess the first port of call is always online. Where would they go, and what do we need to improve that kind of experience?
So we surveyed families and friends of people who are concerned about their loved ones' alcohol or drug use a number of years ago to inform responses to helping them find help and support for themselves and the person they care about. And that told us that people just didn't know the questions to ask. If they weren't someone who used drugs themselves, it was a really foreign space for them to step into. There's lots of shame associated with that problematic alcohol use and illicit drug use. So they didn't want to tell anyone, so they delay help-seeking behaviour. So the first point of call will be online, as you've said. It will be Google. People will, so we've launched a program called Path to Help, which has about between 100 to 120,000 people who come to that service every year, and it's relatively new as a service. And we did that because people wanted anonymous information. And before we launched that, our website, which has about 8 million people visiting it every year, the biggest search on Google that brought people to our website was drug facts. So what are the facts? What does cannabis do? What is nitazene? Just understanding drugs. But then it was drug rehab and detox. And yet when we did the assist using the assist tool, which is a part of the Path to Help program, so they come in, they do a simple clinical screen online, and then we give them results for help and support based on their risk profile. The majority of people didn't need detox and they didn't need rehab. They needed other sorts of services. So people's perceptions about what someone who is experiencing a substance use disorder are influenced by stigma, by public perceptions, by myths around alcohol and drug use. You don't have an alcohol problem until you're someone drinking alcohol from a brown paper bag in a dim part of the city. Those sorts of stories really delay the help-seeking behaviour in the first place. So what can happen is that they'll go online, they may get a sponsored link, which is a treatment provider, so they'll try that. They may get a phone number to call, so they'll try that. They bounce around what we call the front door. So even before they're in the system, when the system is incredibly fragmented because it can take multiple attempts and multiple treatments before you start to experience the sorts of outcomes that you're hoping for, someone might turn up in an emergency department, they may talk to their GP, they may be in a mental health provider, they may be in a domestic violence service, they may be in a homelessness service. They bounce around that front door system, and our view is that we can do so much more to improve that. We can better connect those services at the front door so that they are not bouncing around. We can direct people. Path to Help is not funded to a very high level. We do not promote the service widely. We have a small promotional budget each year, and yet we've still got 120,000 people who are coming to our front door looking for help. And then there are all the state ADIS services that are connected via the national hotline, but Path to Help sees about
What national hotline? Sorry.
So the Australian government has an AOD hotline, the national hotline, which connects people. When you call it, you're diverted to your state ADIS service. Path to Help sees about 4 times as many people online as the national hotline gets calls, partly because people don't want to talk to someone when they're embarrassed and ashamed.
So there's Path to Help, which is an ADF, and then there's a national hotline.
Yes.
So it's a bit not connected.
There is in our submission an image of the various places that people, and they all connect to each other. So we've been talking about the need for work to be done to better understand the way that digital health can be integrated to provide a better experience and outcome for people who use alcohol and drugs and their family and friends. We also believe that digital health can be used to intervene earlier. So 8 million people come to our website every year. They come looking for information about cannabis or nitazines, but we can start the conversation with them about what does risky use look like, how do you know whether you or someone else is starting to move into problematic use? Most people that we speak to, we did a survey of 3,500 Australians who use alcohol and drugs, and the majority of them said we want to do it ourselves. Yeah. And when they do it themselves early enough, you get good outcomes. Yeah. So we're not developing programs and services at that level. We're really focused often on the treatment end because the need is enormous in the treatment space, and many people can't get access to treatment. So by shifting, it's why we say let's build a fence rather than an ambulance at the bottom of the cliff. Let's try and there will still be people who need treatment, but we do think that we can really help people get better outcomes earlier with better early intervention and prevention.
Can I just keep drilling into this a little bit? Sure. In our previous submission, we talked a little bit about an intake triage system. Orange Door in Victoria, I don't know whether you know about it. Is that sort of model something that is needed? Is there because it sounds like you've got a national, you've got a government-funded hotline.
So I think there's 2 parts of it, and Rob, you might want to add more. One is that the decision to ask for help often comes very late in the piece with alcohol and drugs. It can be 18 years from the onset of a substance use disorder to actually looking for help, because stigma is such a driver of shame for people, and they don't know where to go. So there are people who will be in crisis who have significant harm from their substance use, who do need coordinated integrated care, particularly experiencing often many other issues, whether it's mental health, alcohol and drug substance use disorders, experiencing difficulties with housing, employment, etc. But there are 6 million Australians, correct me if I've got that figure wrong, Chloe, who are using alcohol at risky levels. They don't need treatment. They actually just need slight behaviour change to reduce their risks of requiring treatment in the beginning. So I think you're always going to need an online mechanism for helping people understand their risk, intervene early, and then you do need this intake, and the intake systems in every jurisdiction are different. The ADIS, Alcohol and Drug Information Service in every state and territory are different. You don't get the same sort of service in Queensland as you get in New South Wales, as you get in Victoria, as you get in WA. So that this process of understanding that you might need help and support, understanding when and what type, and then accessing it, all needs to be significantly considered. And again, it's cross-jurisdictional.
Yeah.
Did you?
I was just going to say, and then you had the Psychiatrist College here before. You have then even down this end, say a non-government treatment sector. You have government-funded provided services through the states. You have some federal programs through PHNs. You have primary care through GPs. You then have some specialist care through psychiatry. There's then the entire private rehab sector. There's a real, I think, lack of understanding within the general population of what. There was an article on the weekend about a particular celebrity going into rehab, and that's often the framing for drug and alcohol issues. As Erin has said, you don't have a problem until I had to go to rehab, and it's framed as I had to go to this private rehab. But when we work across the population and we say, well, actually there's a very small portion who are down here at this pointy end, and unfortunately I think despite the fact that, you read the news, I should do every day, and you see there's stories about the impacts of alcohol and other drugs on the community, on individuals, every single day in the paper, and yet the responses that we provide, I feel, don't quite match the kind of impacts that it does have on the community. And taking an approach that works right across the community, and as Erin has said, provides inputs for people who don't need this, but might just need some gentle nudging, might need information, may want to talk to someone but only once and online, but providing ways to access that, I think, will make really significant difference and prevent people, instead of there being no fences here, there being multiple fences that stop people ending up right down to that pointy end.
And I don't think you just want one.
Yeah, of course.
No.
I think you'll need multiple. And Path to Help is also funded by the Australian government. They fund us to deliver the service. So,
It needs to be scaled, and it sounds like
and integrated.
yeah, and integrated. And I mean, digital health is a thing. It's scalable. That's the beauty about it. So what you're saying makes perfect sense. Just sort of front load that and prevent this sort of ingress into the acute side of the disease.
And alongside that, I think we also need to address perceptions around what constitutes a point in time where help may be needed. So because of the way alcohol and drug use is portrayed, people often think they don't need help and support unless they're, in their mind, fitting what is a stereotypical perception of someone who uses alcohol and drugs. And with all due respect to the fabulous little video that you did, Mike, about the inquiry, the images in that of someone who's using alcohol are the images of that very stereotypical person who uses alcohol, which sends a message that if you're not using alcohol like that, you don't actually have a problem.
So, Ms Stanley has another question.
When I'm listening to you and, your responses to how we help people are fantastic. Like, I completely understand that. But we need to find a way, and there may be one and I'm just not getting it, for people to have self-awareness of what they're doing is not good for them. So that, and I suspect it would be different for everybody. So some of us have genetic means we're more susceptible to being that person where alcohol becomes a problem or where drugs become a problem. Or, if you're a young woman who's small, alcohol affects you more. How do we... You've talked about stigma a lot, and I absolutely agree with you, but how do we actually, together with those other programs that you're talking about where people reach out, actually educate people that they should think or stop or... because I think, unfortunately, I don't drink. And just because I like to be in control, so drinking is not one of the things that I do. However, I find it really, in some social circumstances, I am unusual and I just get offered it all the time, and you just think, no, could I just have a glass of water? That'd be fine. But we need to be able to say to people, if you do this, there may be concern for your health. Like, where is the education piece before we get to the stigma?
There is so much in that question.
Sorry.
Like I could spend hours talking to you about that particular question, because it really gets to the heart of some of the challenges in this space and the complexity in this space. So we are getting more and more evidence that any alcohol increases your risk of long-term health conditions, particularly cancer. Very low awareness of that in the community. Only 14% of Australians understand that alcohol is linked with breast cancer as an example. So there's misinformation that is promoted through media, social media about, I was reading one yesterday about the fact that you shouldn't drink beer because it's an inflammatory product, but you should drink red wine. Any alcohol is not particularly good for you, but we accept that people will use alcohol. So, and we also know in the illicit drug space that for the vast majority of people, to Rob's point, they will not experience a substance use disorder. They use that substance, whether it's cannabis or heroin or methamphetamine, as a way of improving their life. They get positive benefits from their illicit substance use. And so the risk of criminalisation is the greatest harm those people are at, risk of harm. Then there is the social norms, to your point of you can't go out without someone insisting that you have a glass of wine or a beer or alcohol, because our society and our community is structured around alcohol. The cultural norms that we talked about, many of them reinforced by the industry. If we can get people to understand that you shouldn't be celebrating a grand final without a can of beer in your hand, then we've got a problem. Now we're seeing that impact on young girls, where we've received images of under 15 girls' football teams celebrating their grand final win holding pink drinks that are alcoholic. So I think it's incredibly complex, and it is different between alcohol and illicit drugs, because there is a perception in our community that anyone who uses drugs is bad and all drugs are bad, and actually that's not the case. Alcohol is a very socially accepted drug, and if you don't drink, then you've got a problem, but if you drink too much, then you've got a problem as well. So it is a complex narrative that is influenced by the way our industry works, by our regulation and our laws. We criminalise people who use drugs, therefore we send a message that drugs and those people are bad. So there's lots we could do to change that, but it's not, it will take time and it will take commitment to do so.
It sounds like we need a national regulatory.
I think we need to do both.
Yes, agreed.
Just not.
Absolutely. And that's why in our space we talk about prevention and early intervention, a part of that, and we spend a lot of time and energy and work looking at people who use alcohol and drugs, and at what point we can start to, what's stopping them from understanding the risks. And for many people who use alcohol, it's, I don't think there's a problem with my alcohol use, even though they're using it at risky levels, because their perception of a problematic alcohol use is someone who's got a significant substance use disorder.
Okay, thank you.
I've just got a couple of questions, and suitably chastened about the images.
Sorry.
Video.
But it is an example of
Sure.
how easy it is to send those messages, because they're an accepted way of communicating about AOD.
Sure. So we need a national education program, number one, surely. Isn't that what you're saying?
A targeted education and information program.
Yeah.
So we are recommending health labels on alcohol that tell the person who's consuming that alcohol causes cancer, that alcohol causes liver disease, letting people make informed choices about their alcohol, informed being the word that we use there,
Sure.
informed choices about their use of that product. We also think that we would call them behaviour change campaigns that get people to understand risks and connect them into self-help resources.
Should we also have minimal unit pricing?
So advertising, price, promotion are the three best buys according to the World Health Organisation. Minimum unit price as a state responsibility, we believe it should be in across the country. We also believe that we should change the taxation system to remove wine equalisation tax and introduce a
So volumetric alcohol pricing,
Yep.
you're saying also? Okay.
I remember, was it 2000s? ADF had some fantastic campaigns. I was a youth worker, and they were really, really successful. Posters in classrooms on, the impact. Yeah.
I've just got a couple of other questions as well. Are you seeing increased use of marijuana, or medicinal cannabis as a problem?
This is a really complex space. For a long time, people have used cannabis for multiple reasons.
Sure.
Yes. And some of that use may be medicinal. And so we've always tracked, or at least recently we've tracked in our data when people are using it for medicinal purposes or non-medicinal purposes. But what we see is there's a lot of overlap. People will, and the line between the two isn't necessarily clear. What's concerning us now is I was going to say emerging, but the emerged medicinal cannabis industry that has been, on paper, ostensibly providing a prescription medication, but is acting like some organisations, some companies within the sector, not all, but some are acting in ways that does not align with, I think, the spirit of our health system and the intended spirit of making cannabis available via prescription. It's not to say we don't support people accessing medicinal cannabis. We've been very strong about our support for that, but we're not in favour of companies advertise. I Google cannabis all day because I work in this space, but my social media is just full of ads from medicinal cannabis companies, non-stop. Every second ad is from a medicinal cannabis company pushing and pushing and pushing
I
me.
get one, so it's working for some people.
Just need to start Googling medicinal cannabis.
Clearly, yes.
Yeah.
Actually, now we've been talking about it, I'm sure I'm going to get a lot of
I think the other thing, Mike, I'll just add about medicinal cannabis is that you will have seen in our submission the number of prescriptions for medicinal cannabis has just trended upwards at we would say an alarming rate. But
Can I just say I don't think there is enough medical evidence to justify that either.
for many of them, but the number of people using medicinal cannabis hasn't changed. So what that tells us is that we've got the same number of people using medicinal cannabis, but more of them are getting it on prescription. So we're not quite sure what's going on there. We don't know whether there's an equity issue, whether the people getting it on prescription are those who can afford it. We do know that it's people that are being targeted. But I think the other thing is that when there are commercial interests at play, alcohol, medicinal cannabis, we start to see the impacts of that on health. So better regulation of the medicinal cannabis market to ensure that when it is prescribed, it is done so using appropriate medical thinking. The other thing that we've spoken about is that many Australians have used cannabis, whether it's for medicinal or recreational purposes, and we are seeing internationally a change in the way cannabis is being regulated to enable better access for recreational purposes, and that conversation has started here in this country already. The impact of the way the medicinal cannabis market is being managed on thinking about a regulated recreational market, I think needs to be thought about deeply. When we've looked internationally, we've done a review of international evidence around models of recreational cannabis regulation, and every sign tells us that when there are commercial interests at play in that sort of market, harms are increasing. So if we want to start a conversation, and I think we do want to start a conversation about regulated recreational cannabis, we need to think about the commercial drivers and what the current medicinal cannabis market will do to that conversation.
Another question I have is, are you seeing increased inquiries about new drugs coming into the market? And if so, what are they and what should we be looking for?
There's a few pieces to this. The kind
You
of
mentioned
nitazines. It's effectively there's
and fentanyl. Someone's mentioned, I think. Too.
Yeah, so we use the term potent synthetic opioids is kind of the language we're using at the moment to describe a group of drugs that are very highly potent. So in a tiny, 1 microgram, 10 microgram amount can be fatal, and they're generally newer drugs that we haven't seen in the drug supply before. They may have existed previously, but newer in the drug supply. In terms of responses, we know there's evidence-based measures like drug checking, which are being introduced in a number of jurisdictions. We know that systems that provide information and early warning to people are really important, information for the broader population about risks, because there are people who are using substances like cocaine or MDMA expecting a certain, like a stimulant effect. There may be trace amounts of these drugs which can cause harm or overdose. So it needs to be a population kind of wide effort.
We also know things like medically supervised injecting rooms are a big help for people who are injecting drugs and at higher risk of overdose. So,
And I think you were mentioning pill testing.
yes, yes, drug checking. Yes, that's right.
The early warning systems are really important, and you can collect data about the new drugs, and there's new substances coming in all the time. I mean, nitazenes and fentanyl are the two we talk about because I can say those words. There are some with very long words and lots of numbers in them that completely mystify me, and there are many experts that can talk to you about that.
I'm sorry to interrupt. I'm aware that we're out of time. Is there any way you could put something together about what new inquiries you're seeing? And
Yes, we can.
That just on notice, that would be
Yeah.
great. I better let my colleagues, any other questions, final questions?
I just had one question around home-based care and whether you could make some comment about where we're at with that.
So I think the previous witness provided some really good insights into home-based care, that there are various models for delivering care in the home. For some people that works, for some people they actually need to be out of the home to manage it. Detox in the home is something that, from a digital health perspective, I think provides a lot of opportunity around. There are providers like Clean Slate that are doing some of that work. There are other groups that are providing detox in the home. And of course there's outpatient care as well. So I think a lot of people think about rehabilitation as residential rehabilitation, and it doesn't have to be residential. There are clinicians who will be able to speak about this much more expertly than we could, but there are different models for different people.
I think we're out of time. And thanks very much for your evidence. It's been really very important, very interesting, and there's lots more questions we could ask. But thank you for your evidence today. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Monday, 11th of November 2024. You'll be sent a transcript of your evidence and have an opportunity to request corrections to any transcription errors. And if there's anything else you think the committee should be aware of, please don't hesitate to send it to us. It will be certainly viewed. And once again, thank you for your very valuable time today.
Thank you for the opportunity.
Thank you. I'll now suspend the committee meeting for a short break. I declare reopen this public hearing being held at Mantra on Russell of the House Standing Committee on Health, Aged Care and Sport for the inquiry into the health impacts of alcohol and other drugs in Australia. In accordance with the committee's resolution of the 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published on the Parliament's website. I wish to acknowledge the traditional custodians on whose land we meet and pay respect to their elders, past, present and emerging, of all Australia's Indigenous people. I now welcome the witnesses from the Youth Support and Advocacy Service to give evidence today. For the Hansard record, before giving evidence, would you please state your name and the capacity in which you will appear before the committee? This hearing is a legal proceeding of the Parliament. Giving of false or misleading evidence is a serious matter and may be regarded as contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion. Thank you.
Well, I'm Andrew Brune. I'm the CEO at the Youth Support and Advocacy Service.
And I'm Dom Ennis. I'm the General Manager for Service Development at YSAS.
Really pleased to be meeting here with you on Wurundjeri land today. First of all, I'll just give you a little bit of background on our organisation. We understand that you will have some questions for us, so
Sure.
very happy to answer them and to engage in a discussion. YSAS started life as an organisation in 1998 after the Premier's Drug Advisory Council in Victoria, chaired by David Pennington. There was 31 recommendations. It was an inquiry into illicit substance use. There were 31 recommendations. One of them was to establish a youth substance abuse service, which is our acronym. So we started life as the Youth Substance Abuse Service as a partnership between St Vincent's Hospital Melbourne, Royal Children's Hospital Melbourne, Jesuit Social Services and Turning Point Alcohol and Drug Centre. Turning Point Alcohol and Drug Centre is no longer a shareholder because they joined Eastern Health, so they relinquished their share, but the same three original shareholders that came together to establish this Youth Substance Abuse Service are still around, and they are the shareholders in our company. YSAS is a charity, but it's a company limited by shares. Now, why did they recommend for the establishment of a youth substance abuse service? Because in Victoria at the time, there were no youth-specific services. It was almost impossible to get a drug and alcohol treatment placement, either in residential care or in counselling if you were under 18. I personally was working in the drug and alcohol treatment system at that time, running what you might call an off-books youth-specific service, meaning that we were using different funding, not state government, Department of Health funding, to run a service to meet the need, which was before us, which was substantial, because at the time, you may remember, in Australia there was a heroin epidemic. That I personally knew several young people who died unnecessarily of heroin overdoses. We could not get them into residential withdrawal, safe, stable places to address their drug problems and a lot of the other social issues. So massive advocacy from the youth sector at adolescent health industry to get a youth-specific service system, and that's how YSAS was born. The service types we use and were established to provide, and we still use, was youth outreach. Take the services to the young people, make the right door for them to get through. Don't sit back and wait with no wrong door. Go out there, engage, create the right door. That now goes for South Sudanese young people from Aboriginal and Torres Strait Islander backgrounds, young people who are LGBTQIA+. They've often all got their own requirements for how to make a service accessible and useful and work on their terms. We also run, so we have about 400 staff. We run residential withdrawal services, 2 residential rehabilitation services, a whole range of youth outreach services. So I won't go into great detail, some of it's in the submission. And I'll just hand over to Dom to talk a little bit more about our submission. Yeah.
Thank you. And also like to acknowledge the traditional owners of the land, the Wurundjeri people of the Kulin Nation. And just prior to answering questions, just wanted to pull out 4 or 5 really key points we wanted to specifically emphasise from our submission. And firstly is the critical importance of ensuring we do provide youth-specific AOD responses which meet the unique needs of young people and that target the distinct developmental stages. Really, really important. So Andrew talked about once upon a time we didn't have AOD, youth-specific AOD services. Really important because we believe that youth-specific responses to AOD risk and harm are really necessary because AOD problems are more prevalent and dangerous in adolescence. Adolescence is a key period of development when substance use issues tend to emerge in terms of a life stage. We know that intervention at the earliest possible time leads to far better health outcomes overall. And again, from practice wisdom, from history, we know that there is potential for exploitation and antisocial modelling when young people are grouped together in drug treatment programs and environments with older adults. So that's really important. Secondly, we really strongly recommend a focus and investment on early intervention and indicated prevention responses for young people. These can significantly modify risks and protect health and well-being of individuals, families and communities. We especially highlight the importance of providing integrated services and responses to young people experiencing AOD risk and harm. And we say that understanding that young people with the most severe AOD-related needs and risk and harm almost inevitably have a multitude of co-occurring issues in their life as well, okay, which both impact and are interrelated with their substance use. And so things such as housing instability, mental health concerns, experiences of family violence and obviously family conflict and disconnection from family, childhood trauma, disconnection from school, etc. So, those issues and that holistic response is incredibly important to address AOD issues with other issues concurrently, and that is as opposed to a paradigm which sees drug and alcohol issues as a singular issue or a disorder within a person that can be diagnosed and treated in a very specific way. Very important. Thirdly, we just want to highlight the really key principles of effective services for young people. So they are, as Andrew said, assertive engagement, not waiting for young people, but so really getting in early and having very attractive services for young people, not waiting for them to put their hand up for help. As Andrew again also mentioned, intersectional responses, so recognising that some young people face multiple and then sometimes overlapping forms of disadvantage and discrimination, which makes help seeking and overcoming issues particularly difficult. And effective principles include also trauma-informed responses, person-centred practices, integrated care, as I've mentioned, and family and carer inclusive care. And the last point we wanted to say, we really wanted to promote this idea of place-based and integrated service models for addressing youth AOD need. And when we say place-based services, the unique aspects of those are they explicitly recognise and respond to the environments and the systems that young people live in and grow up in. And, for example, proactively working with families, proactively working with community members and other important people in a young person's life to really build resilience, capacity, and support access to important resources. And again, that is opposed to a paradigm that sees drug and alcohol's need as something that the individual goes to treatment to get just. And then lastly, a really important part of place-based services is being able to dynamically deploy and redeploy resources and the right level of care and the type of care quite flexibly depending on a moment in time where a young person's at in terms of their needs, their motivations, etc. So it's that flexibility to work with young people, again, as opposed to an approach that would be, we have a model of 6 sessions and we do it this way and then we've done and then we go on. So they're the main things we wanted to emphasise, and we look forward to answering specific questions you have of us.
Good, thanks. Jodie, do you want to go first?
I know YSAS. Ipshita Roy.
Yeah.
So,
Okay, yeah, we're still in touch with her. She's
Yes.
not working with us now, but she would have had nearly 20 years with us, I think.
yeah, she did. Yeah.
part of this-
And
part
we've
of
got
our
a YSAS in Dunkley. So,
Good.
yes, which is great. I suppose a couple of questions. I know a lot about the work you do, how you are very place-based. You go into where the young people are particularly, which is fantastic, having been a youth worker in my past. I suppose I'm really interested, and we've heard about this in our other submissions, in the interconnectedness between AOD and mental health and potentially domestic family violence, whether or not you've got anecdotal information or evidence about that influence.
We actually, probably in terms of that family violence area, have quite a lot of evidence and a lot of work in that area. There's a particular researcher who works with us called Bianca Johnson, who would have worked with Ipshita in the past. And one of the things that she's looked into is this issue of coercive control with substance use and intimate partner violence. And that's, in young people, it often gets ignored, but those type of how those relationship dynamics can actually lead to, particularly young women or someone who's on the wrong side of the power dynamic, being put in situations where they don't have agency and can't enact harm reduction strategies, can't access treatment, just like what happens in those type of abusive relationships. But there's more to come on the mental health side. Just sort of Dom rocking in his seat, so I'm going to let him go. No, go Dom.
Can I just interrupt and say, if you do have any data about that, it would be very good if we could have...
I'll tune in with Bianca and I'll follow up with you on that, because she's doing her PhD on that particular issue. She's only got a year to go, so she would really appreciate a forum to be heard in that way. Just the other one before Dom chips in, just around the sort of coexisting alcohol and drug and mental health concerns. Just going back around alcohol and drug problems, and if you think of the word addiction, it actually there's so many ways to characterise and describe addiction, so many models of dependence. There's an old book by a guy called Stanton Peele, it's called Visions of Addiction, and it had 187 different models of dependence. So there's contested views about what are the drivers or what are the determinants of drug problems. We tend to come more from the social determinants of health, kind of public health approach. But there are different views, and we all know there's disease models and there's other etc. In the end, what we care about is that addiction characterised by loss of control is, for the young people we work with, what are the reasons they are experiencing a loss of control, a loss of agency, and a loss of connection to a more productive, positive developmental pathway in their life. And that's one of the key harms, that if young people do get come to rely on substances, there's obviously immediate harms and direct harms to be concerned about, but there is developmental harm that can occur. And so we are trying to create the conditions where young people have a viable alternative pathway, where they're not relying on drugs for answers, where they're not getting caught up in drug-using lifestyles and drifting, dropping out of education, not entering the workforce, having family disconnections and dissonance, etc. So our concern then is with each young person, not so much about what the different visions of addiction and theories of models of dependence are, is to say, let's really get to know each young person in the context of their family and community, and understand what is it that is creating the conditions where they come to rely on drugs for answers in their lives or to meet needs in their lives. How can we help young people see different ways to meet their needs so that they don't need to rely on drugs for answers? In that way, as a youth-specific provider, we're not saying don't do this, don't do this, don't do this. We're saying, hey, we understand, you understand the function, the reason you're using. Here's another way. We understand what those underlying drivers and needs are. Here's another way to deal with your trauma, etc. So I'm getting back to the mental health side of things, but it's just to say, we understand there's many coexisting issues, conditions that interrelate with the drug and alcohol use and that loss of control and the harms that they can experience. So I think we are careful not to be too reductionist about it. It's one thing or the other. It's interrelated. There's a chicken and egg issue. Sometimes substance use is exacerbating someone's depression, anxiety, etc., psychosis. Sometimes it's the depression and anxiety that's causing the person to seek answers. So we have to understand, why are they seeking answers? What answers are they seeking? And then try and provide healthy, constructive alternatives which lead to a longer term, better outcome for them. Because the key thing about substance use, when you come to rely on substances, the psychoactive effect will give you an effect. It changes mood, cognition, behaviour. So it will work in the immediate. So if you want to block out your life, if you've got a lot of trauma, you're getting flashbacks, you can take particular drugs and they'll stop you from thinking about those things and stop you from feeling. But eventually you'll start feeling again and you won't have solved the problem. You probably will have served to entrench that problem even further. So when we're thinking about our services, it's always about how can we create the engagement with kids who are using substances. So we're ready when there's a window of opportunity to show them there's a different pathway. We are connected with them. We are ready. We know their family. We know their community. I'm on a serious ramble on Hansard here, so I need to pass over to Mike.
Look, you've probably covered everything, Andrew. I would probably just add that, yes, as Andrew said, it's a very common presentation that young people would have co-occurring issues of substance use, obviously, and health. And as Andrew also said, it's there's anecdotally every individual will have a different experience of the interplay between those two things, which then speaks to this idea of having very person-centred care approaches. Really, we've got this treatment, we're hoping to apply it to everyone. Much more of a understanding, learning about individual. That only comes with really good engagement. And probably the only other thing I'd say is, because we work with young people, increasingly we have a lot of young people that have formal diagnoses of mental health concerns, but we also have a lot of young people. The further upstream, because we're talking about young people, the further that there is less sort of diagnosable issues, but just emerging behaviours, issues, concerns, both with AOD. And so we talk about this idea of a trans-diagnostic approach, which is, it's not so much about we've got a diagnosis of mental health and then a substance use disorder diagnosis. It's about what is the need, because often a 15, 16-year-old will just have a whole lot of things going on, and it's really good care and practitioners to learn, understand, work with families and communities to say, how can we meet these needs, which will have a longer-term good impact. Hope that's...
One quick question. Do you think there is enough, there's a person-centred approach is adopted commonly across the sector to deal with the AOD and the trauma or the mental health? Is that common practice? Sorry, I've got to get my question right.
It depends on what part of the sector. I think definitely the youth alcohol and drug service system, which tends to be more psychosocial services, and important to say, with medical practitioners and nurses tuned into it. So I think it is a person-centred. The aspiration is to be person-centred. I think there's probably examples in more adult services where it's a little bit more system centred. So you're requiring the adult to fit into the system, if you know what I mean. We're trying to shape our services around young people, but so there's a tension there.
And the history of the two, like the history of the youth AOD service system, as Andrew said, he was part of it, sort of bubbled up out of youth and social work principles. And I think there are still, I think some of how our services are commissioned and how we report and how they are funded tend to lend themselves more to the blocks of activities in the individual. So I think the practitioners and the spirit of the work across youth and adult are very much person-centred, but that's often hard with the I guess the models of activity-based funding and different types of funding.
Can I just follow on from that? And I'll just not take up too much time answering this, but I don't think that it's a very human-centred, person-centred system for families seeking help for their loved ones, for their young people who they care for, or for any others in their lives. I think system navigation is a nightmare for people, and I think you're going to hear that a lot. You're going to hear it in Brisbane, you're going to hear it no matter where you go. In the youth system here, it's smaller. It started, as I mentioned, out of that inquiry. It had a big focus on outreach and connection, and so it runs differently because we are free to take out with outreach to take our services to young people, and we're really advocating for some more of these place-based services where you have day activity kind of programs where you can run programs in youth-friendly environments that they feel a sense of ownership and safety and connection to. So we're having this great success in Dandenong. We're engaging a lot of African diaspora young people, particularly South Sudanese, Pacific Islander background young people, to a lesser extent, but still some Aboriginal young people. To the extent that I think those three groups make up about 90% of that particular site's target group, but that's, like Don was saying before, it's place-based. But the fact that they can come into a safe place when they need it, they know exactly when it's going to be there, and then our workers can go out to them from there when they make the connections. It's the way to keep in touch with these groups. And then what we do is we can bring in medical practitioners, we can bring in Centrelink, we can bring in the lawyers, and it's working out really well. But the state system here in Victoria, there's a new alcohol and drug strategy being planned, so we'll see what the service system looks like. But we know how we'd like it to be. So,
Michelle.
Yeah, thank you. Just with regards to information seeking, I would have thought, and I did ask this of the previous group, that the first port of call would be online. What sort of improvements need to be made in that space, particularly for young people?
So we recognise this at YSAS and the youth sector more broadly about 10 years ago, and we set up a new service called Youth Drug and Alcohol Advice, which has an acronym called YODA, and that was in recognising that before that time we mostly had helplines, so mostly had phone lines, which are still fantastic, but we recognise you need a multitude of channels. So I would say it's not just about online. You have to be able to. It's really similar concept about we have to take, whether it's information or treatment services, we have to have attractive ways of proactively engaging young people where they are. So young people are online, they're on TikTok, for instance, then we need to have information about drugs and alcohol and where to get help, etc. Similarly, websites and different places like that. What's really difficult, though, is there's so much information. So having information is not the problem. It's about getting the right information to young people and families at the right time. And so there still is that need for people, if that makes sense. So one of the models of YODA that we set up was every bit of information we had out there, in order to reach as many people as possible, still had pick up the phone and talk to us, or email us, or chat. So many mediums, because that's probably the hardest thing with good our AOD information is there is so much information, and so much of it is really not good and not evidence informed. And so I think that's the case with any topic online. It's about how do we cut through and get to the right people at the right time. So,
do you know the thing that Yoda does, which is following on from the online question, but and Dom actually established this service some years ago, and we ran it off our own funding for a long time, and now we have state government funding for it, so it's an endorsed part of the service system here. But they run this next step service. So instead of saying we're going to do online treatment with or phone treatment, it's we are going to make a connection with you, understand what you need, understand what your concerns are. That's if you're a young person yourself, or if you're a family member, can even be another worker, and we're going to help you get to the right place, get the information you need, like the interpretation of the information you need, or get to the right place if you need it. And we found that we had so many parents ringing up saying my kid needs rehab, because everyone thinks that's what they immediately think. And of course, maybe 20% of them did. So previously, they would all just run a drug and alcohol treatment service and got on the waiting list, and you've got 100 people on the waiting list that don't need to be there. So it was just so good to be able to then say, what do you really need now, to then start going through, how could you talk to a young person about this in a different way? You can allay their anxieties, and then if you have to, you then work on navigating the service system. So you go right from that online phone through to just helping them make the connections. And it's been a really successful service, and I'd just love to see that type of service available for people around Australia.
And the next follow-up question is around parents. So I guess the first thing is, to what extent does parental behaviour influence young people's drug and alcohol seeking or experimentation? That's the first thing. So parents as a driver, in other words, versus then parents. What is the role of a parent when their child is suffering from or in the early stages of a dependency?
Can I grab this window?
Or risky behaviour.
I'll value add.
Yeah, no, good. So the first thing is parents and families are extremely influential. They're influential in the solutions. They can be very influential in the development of problems and the exacerbation of problems. That is not blaming parents. That's understanding the family as a system. And it's actually a reason why it's been so problematic that the history of the drug and alcohol treatment system has been to leave families out. You actually have to bring them in and try and get those dynamics shaped so they're going to support healthy and positive development. And then the second part of the question is with adolescents, around substance use, around a whole range of other potentially risky behaviours, parents need to set boundaries. And then the question is how they set their boundaries. So if you set very hardline boundaries and I'm going to kick you out if I catch you using drugs or something, a parent will often find themselves, and we've had them ringing us so many times, I've said I'm going to kick the kid out if they smoke marijuana, and now they have, but I don't want to kick them out. What am I going to do? So then you have to work those issues through in those dynamics and get the best solution. But it's always useful when a parent is setting some boundaries, and there's a way of doing that which will engage the kid or their child in the most constructive and most sort of positive way and get the best behaviour outcomes. But it's always good to have someone outside of that nuclear family structure who's doing the limit setting to be around, to be able to give the kids information, to know what's going on in their life, because once you set rules and boundaries around something, it means that the kid will not then has got a reason to hide some of that away from you. And that's the consequence of setting the rules and the boundaries, which is right. So you have to have ways to make sure you know also what's going on. And that's why having a family who's got sort of drug and alcohol issues connected to whether it's the right type of treatment providers, youth workers, school counsellors, but uncles, aunts, cousins, cultural leaders, they become very important in supporting the family to set those boundaries and rules and help the kid work their way through this adolescent period where, as we know, they are trying to develop their own identity, to assert themselves. So I'm going to decide what I do here and there. So it's a tension and a balance that every adolescent, we both are. We both have adolescent children, and we're both going through that process where they're asserting themselves and developing their identity, and eventually they'll be adults living in the world with us, hopefully, alongside us.
Sure.
Yeah.
Never adults.
Yeah, well, yeah, I'm sure.
I've got a completely different question. Our two witnesses this morning have asked about, or I've asked them about the differences that youth, there's a reduction in youth using alcohol significant enough that everybody's talking about that. Are you seeing that? And my question is that being substituted with something else? Because, quite frankly, over the last 100 years, youth have always been the ones, this is the time in their life when they are experiencing this. So are they substituting it with something else? Or are they really getting the message we're trying to give them, in primary school about healthy options and so forth? And then when they get to 18, the last witness said it's ramping up exponentially. So where does your program finish? Like, what age group does your program finish? And have you got any view about that?
You can answer, Doc.
I'll start. Yeah, there's a couple of things in your question there. One is that, without having the data in front of me, I'm also aware that whole of population data does seem to suggest that young people, for instance, are drinking less than their generations before, and I think people in their 50s and 60s are the highest consumers of alcohol in Australia. So that does seem to be the case. Young people that need help and support because things get out of control are not the general population. So they're part of the general population, but there are very particular groups of young people that will end up needing, and we were saying in the break, is that when we look at our data across decades, like we've been around for 25, getting on for 30 years, we can quite clearly...
Old enough.
That's right. We're past our adolescence.
Yeah.
We can clearly map the types of substances that young people say, this is my problem, and we can map that against some of the other issues that I spoke about before, mental health concerns, family disconnection, involvement with the justice system, suicidal ideation, etc. And what we find time after time that we do that is that absolutely drug use patterns change all of the time. We talked about heroin epidemics, then 5 or 6 years ago we were talking about highly available methamphetamines. The witnesses before, we agreed, talked about sort of the potent synthetic opioids that we're worried about. Drug use patterns absolutely change, but for the group of young people that tend to need that pointy end support, their issues are similar. So again, I haven't got the data in front of me, we could take that on notice, but whilst the whole population of young people are probably using and drinking less and delaying the starts of drinking, for the people that have problems, the harms that come from drinking are very extreme, and they're still there.
So we have the same level of demand.
So basically, while the whole of population data shows a decrease, for those, doesn't matter what the drug of choice is, alcohol or whatever, you are still seeing that you need to give them it.
Yes.
Okay. I have a left field question. Do you think that the behaviour of sports people, particularly as I come from New South Wales and have been horrified by some of the behaviour of some of our rugby league players and Mad Monday and so forth, do you see a spike? Because the AFL has had similar concerns, I've
recently.
read. I mean,
Yep.
soccer as well. Do you see a spike? Do you think that youth actually do see these people as role models and it's okay? I know that we've heard about influencers and so forth. Are they more likely in the social media realm to be giving kids not the excuse, but allowing them to do it? Or do you think it is actually the individual's circumstances that are the major reason why they do what they do?
I think it's much more the circumstances. I think some of those behaviours don't help, like in terms of what messages it's sending. One of the things we did a qualitative study a long time ago internally with our young people using our services, and the people that were most influential on them were clearly their peers.
Right. Okay.
And the people who were most influenced on how they think and how they engage with the world were the people who they were looking up to, who were in their social scene, who are a little bit older and seem to be more competent and masterful and things like that. And sometimes that's in an antisocial way as well as So it was more the people closely involved in their world, and then the underlying drivers and circumstances, like we talked about. And having said that, the kind of renegade sports stars and some of the culture around drinking and other things is not helpful. So, but I couldn't.
But it's
make
more
a
likely.
definitive statement. I can definitely tell you it's more likely, because we've asked those young people to use our services for those young people in their world that they're with every day. Yeah.
How do you, as a service, measure your effectiveness?
This is a good question. It's something we were going to open with. At the moment, we have a few ways to do it. We are involved in some research that's kind of longer term. Some of the qualitative research gives us better, richer data, and we've got a fair bit of that under our belt. We have a program now called the Youth Peer Advocates. So we have paid ex-service users from YSAS working with us that we can consult with, and we have a big youth participation program that Dom is responsible for, just overseeing, and it's pretty comprehensive with youth advisory groups, etc. We're now doing, on a routine basis, we're using the Net Promoter Score, which is where we're asking every young person who uses our service a simple question, which is, would you recommend this service to someone in a similar situation to you, or a family member, something like that? And you end up with a group of promoters who are scoring you 9 and 10, and you end up with a group of detractors which are scoring you 6 and 7 under, 6 and below, and you average that all out, and then you have a net promoter score which tells you how valuable your service is, and that tends to be a proxy, and there's a bit of evidence for this. That's a proxy for service quality, and also for outcomes. We're also running a client experience survey where young people who've used our services can contact us. Everyone gets contacted, and they can contact us to have an interview with someone who'll talk to them, and we actually pay them a little bit for that, so give an incentive to provide that feedback. The one thing that we need to do better at, so there's all of those, that all matters, right? So what people's opinions are and things. But we've got a practice framework which I think is pretty clear on some outcome measures that we think really matter. And we are doing work at the moment to try and develop robust mechanisms to be able to prove that we're achieving those outcomes, not just on worker report, like in the database or young person's report, but actually more robust mechanisms. And then we want to do a lot of work around what that impact is and what the avoided cost would be to the community. But we're in that endeavour at the moment. We don't really get funded to do that. So we value it, and so we're dedicating our own resources to that work.
So do you think on that basis that seeing as you don't get funding, and
For that.
clearly knowing that you are effective. Like, I'm not suggesting you're not effective,
right.
but being able to say, I am effective,
Yep.
and these are the programs that we could perhaps put in the western suburbs of Sydney or
That's right.
Brisbane or whatever the equivalent in Perth and Adelaide or Tasmania are. Do you think that would be useful? Like
be
that,
very useful.
and that would actually make you, or give you the ability to make sure that what you're providing is fit for purpose?
We would be very interested and committed to outcome-based funding, right? And like I said, I know, for example, NOFS Foundation or NOFS in Sydney, they're engaged in the same type of endeavour,
Yep.
trying to get those robust outcome measures, robust ways to measure
Yep.
those outcomes. Once we get them, we can learn so much more about our effectiveness and our impact, and so we're committed to it. But you just a word of warning: don't just do that and forget about the activity part of the funding. So you still need to make sure kids get enough dose, so to speak, enough of the contact. If you just set up a system without outcome-based funding, there's potential for gaming that system is high, and it happened in the Job Services Australia area where they were getting funded on outcomes and not actually putting in the work, so that they'd work out a way to game. So you just have a blend between outcomes and activity, and then I think we'll have a really good performance-based
I
system.
mean,
I might,
you can't. Yeah, you have to have both. You can't do one.
Yeah.
I'll just interrupt there. I've got a couple of specific questions. Are you seeing any trends now in the types of drugs people are using? Number one. And number two, are you seeing the effect of criminalisation on some of these behaviours?
Number two, first, we see the effect of criminalisation on the behaviours. So a lot of our young people, I think there's some data in the actual submission, have either had contact or have current contact with the criminal justice system. It's not always because of drug-related crime or drug-specific crime. But I think that issue of criminalisation is an issue, and it's not helpful to someone's recovery, so to speak. In terms of drug trends, Dom, it depends a little bit on the populations that you're working with. As I mentioned before, we're working with a lot of young people from the out-of-home care system as well as the youth justice system, and they're all minors, and some of the substances that that we're concerned about are things like GHB, which is easily accessible, cheap. It's hard to know how much you're taking unless you measure it out properly. It's unregulated because it's an illegal substance. So that combined with other substances like alcohol, benzodiazepines, essentially the kids that we're working with who are most disadvantaged will use what they can get their hands on, and they're highly influenced by others in their world. And the other one, which is not the sports stars, but is they call them the child protection world persons of interest. So 30-year-olds, going back to that family violence, that violence and coercive control issue, where you've got people exploiting those young people, and drugs are often implicated in the exploitation, in the attraction of the young people with the provision of drugs, and then coercive control about how they're used. So it's often combined with sexual exploitation, which is slightly off your question, but it's very relevant because a lot of them are using what they can get their hands on at that younger age.
That's one of the differences of a youth service, is that there's not as many people that have had 30 years using a particular, that's my drug, etc. And as Andrew said, we will find groups of young people in certain locations where there's a particular market or a grey market or as you said, a person distributing, so that will really affect the local drug using profile. Across all of our services, all of our statewide services, cannabis, alcohol, amphetamines remain sort of the three mostly used, but it's important to say that that doesn't paint the picture. When we're talking about people using cannabis, we're talking about people using cannabis all day, every day, and not able to sort of do much else. And same with alcohol, we're talking about young people that are going to accident and emergency frequently and drinking to the point of blackout and being in. So the actual drug is one part of it, but they're the sort of the three most commonly used from a whole of our service system.
And when we started, like I said at the beginning, after the Premier's Drug Advisory Council and the heroin epidemic, our first 100 clients, we did a study on them. This is in 1998 or whatever. It was published in 99. 99 had heroin as their drug of choice. So that was because it was so available and there was an epidemic. And so we are concerned about the next epidemic, and we do think it will be in some form of synthetic opiate or benzo. And we're very, very worried about it.
It's why you also have to have... So we're both arguing for the fact that at the end of the day, it's person-centred. It's not about the drug, it's person-centred. It's about all that practice approach we've talked about. But it's also extremely important to have a very strong harm reduction approach and safety approach more broadly. And I just wanted to also highlight what Andrew said about the youth participation. Critical is listening to how young people would like services to be developed, and that's been huge in how we orient our services and how we make them attractive, is listening to the people that need the services. What do they think? And
we've now got a family reference group. It's just started, funded by the Felton Bequest. So we're very happy to have that.
All right, we'll better move on in the interest of time. Mr. Lisa, do you have any questions?
Mike, no questions at this point.
Great, thanks. Well, any other questions? No? Well, thank you very much for giving evidence today. If you've been asked to provide any additional information, could you please forward it to the Secretariat by no later than Monday, the 11th of November 2024. You'll be sent a transcript of your evidence and will have an opportunity to request corrections to any transcription errors. And once again, thank you very much for giving us your time.
Thanks for the opportunity.
thank you very much.
Much appreciated.
Thank you. I now call witnesses from Reconnection. Thank you. I now welcome witnesses from Reconnection to give evidence today. For the Hansard record, would you please state your name and the capacity in which you appear before the committee before giving evidence. This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as a contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion. Thank you. Welcome.
Well, thank you. Thank you very much for this opportunity and the invitation to attend this public hearing today. We really appreciate your recognition of the importance and the unique perspective that we bring to this discussion. My name is Erin. I am a psychologist and benzodiazepine withdrawal counsellor at Reconnection, and I'm also the research and innovation lead at Reconnection. I was going to introduce people, but I feel like probably we can do it for ourselves.
Sure.
So,
I'm James. I'm the team leader and also a benzo withdrawal counsellor at Reconnection.
Hi everyone, I'm Nick Teo. I'm the Program Director for EACH's Mental Health and Alcohol and Other Drug Services.
Andrew Mao, I am the GP Clinical Lead for EACH, and I work in inpatient drug and alcohol services.
So this brings me to why we're here today. And really we're here to talk about obviously the harms related to benzodiazepines, which we argue are largely hidden and unaddressed in Australia. And we touch on this in great detail in our submission. But just briefly, some of those harms related to those medications I'll just highlight right now for your reference. So benzodiazepines are prescriptions that are commonly prescribed for anxiety and insomnia. They are only indicated for short-term use because when people take them regularly, we see that there's quite a high risk for dependence. So for people who are taking them for 6 months or longer, up to 80% of those will experience withdrawal if they try to stop their medications. But it is the statistics around overdose deaths that are of gravest concern to Australia and to our service that we think is really an unaddressed issue. And this is in relation to their contribution to polysubstance overdose deaths. So 3/4 of overdose deaths in Australia involve multiple substances, and 2/3 of those benzodiazepines are involved. So they are the leading single drug contributor to overdose deaths in Australia. This is also true for drug-induced suicides, where they're the leading medication, pharmaceutical involved in those deaths as well. And yet there's no campaign around raising awareness in the community specific to benzodiazepines in management of these harms. And the issue is these rates have doubled over the last 20 years. So it's a rising issue in Australia, but we would say it's more of a shadow epidemic, often overshadowed by the harms related to opioids. There are a lot of harms that are uniquely experienced by older adults who are disproportionately prescribed these medications. They're 30 to 40% more likely to be prescribed and be on them long term. And for people who are taking these medications over 65, they're more than double their likelihood of having a fall and having a hip fracture has doubled because of this medication. So as you can imagine, the treatment and addressing a lot of these issues does require specialist involvement. So that brings me to a little bit about Reconnection, who we are. We were established in 1986, a small not-for-profit service to address the issue of iatrogenic dependence, which is that dependence resulting from prescribed use. Relatively quickly after we started, we were funded by the Victorian government, recognising the need for our service, and they've continued to fund us for over 3 decades. But just this year, in June 2024, they significantly cut our funding, which means we don't have certainty in funding beyond June 2025. So, and this is, I guess, despite the fact that mental health issues aren't on the decline, they're on the rise, which means these issues aren't going away. Just briefly, some of the services that we provide. We have a telephone and support line, which provides information for consumers and healthcare providers. Even though it's a state-funded service, we respond to calls around Australia and internationally, really highlighting the fact that there is a need for a telephone support line like this, being able to give specialist information and support for people on these medications. This is another unfunded service. We do have a support line coordinator who is funded part-time, but as you imagine, that limits the capacity of the support line quite a bit. But although it's a small support line, its impacts are large. I have an example of a quote from someone who called from Queensland just last week. Finally, after 3 months searching for competent health professional help, I am now equipped with the pieces of the tapering jigsaw to be able to present to my GP who had no knowledge of what to do. Thank you. That's an example of the sort of support that we're providing in the community, but often it's GPs calling the support line as well. So one of the services we offer specific to GPs is secondary consultations, where they can have one-on-one sessions with one of our benzo counsellors to provide that more individualised and specialised advice for their patient. We also provide treatment and support for individuals wanting to come off these medications. So we have a team of clinicians that provide one-on-one therapeutic support that we provide in collaboration with their GP. So we're working with GPs in the community, giving them education about how to safely reduce these medications, and we develop the reduction plan that's tailored to that individual. In addition, we provide education and training. We're always focused on upskilling the AOD workforce, but primarily we're targeting GPs because, fairly or unfairly, the onus of responsibility really largely falls in their lap. And so for us, this is why we also throw all of our research efforts at supporting GPs presently. And finally, we're funded to do some early intervention work, which has seen us develop an entirely free sleep intervention for Victorians. So we're providing free sleep treatment so that people don't need to be prescribed a sleeping pill. We've had over 400 people come into that program. It's unfunded, but we wanted to do a research evaluation of that to establish whether a population level intervention like that would be effective, and we've got that data now to show that it is. So as you can see, we have a range of services that we provide, and we don't think that those services should be limited to people in the Victorian state. We don't think people should have limitations on access based on their postcode. We really urge you to consider the potential implications for a service like ours beyond treating medication harms related to benzodiazepines. We know that there's rising issues with concerns around antidepressant use in the community as well that are highly prescribed, and now we know that often people do need a gradual taper from these medications as well, which is now a priority with the Australian government.
So do you get involved in that space as well, or just strictly benzos?
No, we are hoping to step into that space, yes. Currently we have developed a research proposal and we're looking to get that proposal funded so we can establish what are the nuances and what are the differences in working with antidepressants.
Right, I might open up for questions, but first of all, I'll get all committee members to state who they are.
Anne Stanley, I'm a member for Warrawong.
Mike Freelander, Chair of the Committee, Member for Macarthur and South Western Sydney.
Jodie Ballier, Member for Dunkley.
Michelle Nandaraja, Member for Higgins.
Julian, we'll go to you if you'd like to.
I'm Julian Leeser, the Member for Round Sydney, on my way to Melbourne.
Good. I might get you to start with questions, Julian.
Thank you so much, Mr. Chairman, and thank you for being with us today. Look, I was interested in some of the nature of the people who are addicted to benzodiazepine. Can you give us some sort of demographic analysis? Does it tend to be older people, given what you were talking about in relation to sort of hip replacements and falls, or is it younger people, more men or women? What can you tell us about the demographics of the relevant group?
Yeah, so we could probably speak to that in two ways. Firstly, who's most commonly prescribed, and it is generally more female than male people that are prescribed benzos, middle age onwards, so peaks in people over 45 to 55, and again in older adults. Really disproportionately, older adults are really prescribed benzodiazepines and Z drugs quite widely. In terms of who's accessing our service and engaging with the service, it is across the spectrum. We're an adult service, so from 18, I think my oldest client was 82, but we've had older clients, I believe.
Yes, I think our oldest client is 87, I think, and even though we don't work with young people, for instance, I've been invited out to YSAS a couple of times to do some training with them on how to work with harm minimisation around benzos and that kind of thing. So it does crop up in younger populations as well.
But primarily, I guess, people are coming to our service because they're taking these medications likely as prescribed, at some point have decided they might not want to keep taking them, they stop and they experience withdrawal quite rapidly within 1 to 2 days, and then suddenly, you know, reach out for support because they weren't aware or prepared for the fact that they would experience withdrawal. So it can be quite a long process between raising awareness and getting people actually ready to navigate withdrawal. That's why the support line works so well with the treatment service, because people often engage with the support line for quite some time before they say, okay, I think I'm ready.
For the record, could you state what medications they're called, what the names of some of them?
Yeah, so some examples of benzodiazepines are things like diazepam or Valium, temazepam, Xanax, alprazolam, common names that people might be familiar with. But we also treat Z drugs or non-benzodiazepine hypnotics the same way. They're things like Stilnox, Imivane, that you might be familiar with as well.
Thank you.
Sorry, I think Julian...
And how is withdrawal from these drugs different to of drugs, and what do you need to prepare the person for in relation to drugs? What constitutes successful treatments as withdrawal is going on?
I think that's a really nice point to highlight, the fact that treatment for benzodependence and withdrawal is quite unique because there is no medicalised treatment. There's no recommended medications to help people come off, as there is with opioids and pharmacotherapy, to help people safely come off and kind of mitigate the impact of withdrawal symptoms. With benzodiazepines, it just has to be a gradual reduction. That's the only way they can really manage the severity of potential symptoms, with which if people stop cold turkey, we're talking about seizures and quite life-threatening symptoms, similar to alcohol withdrawal, because they work in similar ways in the brain. But what's typical when people want to come off these is a rebound of their original symptoms. So if I took them for panic, I will have panicking symptoms at a higher intensity when I try to come off. So most people perceive that as my original problem is there, I still need this medication. So it can be a bit of a trial and error process for people to find their feet with withdrawal. And there's such a huge spectrum of potential withdrawal symptoms as well. Physical, cognitive, emotional, it spans all of those domains. So it can be quite impairing for a lot of people. I think roughly 50% of the people in our service cannot work because of their withdrawal. So it can be quite debilitating, and the issue is if you reduce too rapidly, you put yourself at risk of having a more prolonged withdrawal. So there's no grinning and bearing it, there's no white knuckling with benzo withdrawal because you make it worse. You sensitise your system to withdrawal and then it becomes harder to come off. So there's no way to fast track it, it's just slow, steady reductions based on the individual's needs.
And is there some recognised standard procedures that are followed by health authorities for taking people off these drugs, or does it not work like that? And that's one of the things you're trying to encourage us to look at.
So recently, actually, at the beginning of 2024, the Maudsley in the UK, the Maudsley Hospital is well regarded for their psychiatric prescribing guidelines. They have released de-prescribing guidelines for antidepressants and benzodiazepines. And these guidelines are the most comprehensive guidelines we have to date. They build on a lot of the work that was already done in the 80s and 90s by Heather Ashton, but it's the first time a medical authority has really come out and laid out the clear guidelines for how to de-prescribe. Because guidelines prior to that were fairly general. They would say reduce by about 25% every 1 to 4 weeks, or what your patient can tolerate. Whereas this gives quite clear guidelines around risk factors that map on to what rate. So a 5% reduction rate versus a 10% versus a 20%. So it gets into a lot more detail that helps prescribers to have confidence to start the process, because it's letting them know what you need to look out for, what you need to tune into in a way that guidelines never have before. So this is something we're really getting behind and wanting to put a lot of support towards GPs to translate these into practice. It's all very well and good to have this comprehensive set of guidelines, but they are big. It needs somebody to support their translation into practice.
A final question for me. To what extent are the manufacturers of these drugs involved in some of the treatments around the withdrawal process and so on, and have they been involved in looking at the mitigation of some of these side effects, or that's just not their role in the system?
Not that we are aware of or have experienced, no.
I'm not aware of that either. I do know...
No.
Yeah, not aware of that, and there've been some sort of... there've been supply chain issues as well recently, so that's been a bit of a tricky thing with the manufacture of the medications, and some clients finding themselves in a tricky spot without a steady supply to taper off, and people actually having to speed up their taper because they're running out of a medication that's being manufactured. So, not to my knowledge.
Thanks, Mr. Chairman.
Thanks, Julian. I will mention, I'll just have to get someone to move. I have to step out shortly, but don't go away because I've got some really, a lot of questions I want to ask you. So, Jodie, could you move that perhaps Anne takes over as temporary chair?
I would like to move that Anne Stanley takes over as temporary chair.
Only deputy chair because Anne is here in the room, so it's easy for her to
Do we need a second?
manage. Yeah, can you
I'll second.
second? And I will just step out for about 10 minutes, so I can leave it to you to thank. So
Julian,
excuse
have
me
you
for
got
10
any
minutes.
more questions?
No, I'm finished, Dan. Thank you.
Thanks.
And I'll need to actually hop off in about 10 minutes.
Okay, no worries. Thank you. Michelle, do you want to go first?
So thank you for coming, and you're in my electorate, and I did ask that you do turn up for this, so I'm super happy that you have come. And I would agree that I think trying to manage benzo withdrawal is really challenging. I used to see a lot of dependency when I worked at the Alfred amongst older patients, and you just could not convince them to come off their drugs. Even with a recommendation to the GP, it was very difficult for GPs to take these patients off these medications if they'd been on them for years. And then we had a case also where a patient did have a seizure because they were unrecognised as being benzodependent. And obviously came into hospital, the drug wasn't given, there was a prescribing problem, and the patient had a seizure, and then the penny dropped what was actually going on. So I think it's a really challenging area. I guess my question is, a few questions. The first is that this is an iatrogenic problem, and which begs the question, what kind of restrictions should be placed on prescribing? And do we have them currently? Do we have authority scripts for these drugs? If not, why not? Shouldn't we be looking at that as a clear, very simple, across-the-board lever to limit the use of these drugs at the very beginning?
I think several years ago this did happen with regard to alprazolam or Xanax, which has a much shorter half-life, is quite potent, and so probably had more of that abuse profile. It was suddenly a controlled prescription. And what we saw in relation to that was that people were finding other ways to access it. So sometimes the trends are that the more controls that are put in place doesn't necessarily resolve the issue, it diverts the issue, and that people are finding it through private prescriptions in different quantities, or certainly street use became more common even in the last 12 months. I think New South Wales had the biggest, they found 700 kilos of Xanax trying to be imported into New South Wales. So I'm not sure that increased controls are necessarily the answer, because we know that the issue will probably pop up somewhere else if people can't access it. And unfortunately, with the rise of novel and synthetic benzodiazepines, that does put people at even more increased risk of harm.
But should there be at least an authority or a restricted, meaning in the sense that you call that number to Canberra and at least the patient is registered, so they don't doctor shop, for example, so we're not necessarily stopping prescription, but we're monitoring who's getting what.
We have SafeScript, of course, but there are limitations with SafeScript. As most GPs will practice in a siloed manner. One of the problems is when we have a discharge from a psychiatric hospital and then we have a legitimised script, let's say for benzodiazepines, without a planned withdrawal, that can just go on indefinitely.
Yeah, right.
And so I think that SafeScript has got significant limitations.
Can you talk about SafeScript? What is it?
SafeScript is real-time medication monitoring. It involves doctors as well as pharmacists. We can see when a patient has been prescribed medication and when it has been dispensed. There's a red flag system for when multiple practitioners have been approached for scripts. And one of the problems with the SafeScript is that as a GP, if you see the red flag, you're more likely to say, I'm not going to give you the script, which leaves a vulnerable patient in a more vulnerable state and potentially stigmatised. So it's a bit of a blunt method of dealing with the problem, and it's punitive. What we're proposing is that perhaps that should be a flag to come into a more comprehensive treatment.
To link to perhaps a withdrawal pathway, for example. That's a really good idea.
That's right.
The other question really relates to the fact that I really like your model of education, actually. I think the work you're doing directly with patients is super important, but actually probably the most scalable aspect is the work that you're doing with providers, right? Yes. And I would agree that a lot of hand-holding is needed in this space. Could you perhaps tease out what a scalable model would look like in that space, particularly for providers?
So we're already, the Victorian government funded a small research project for us to lead around cross-sector collaboration, to be working with GPs more closely. They're very keen to see what they could learn across the sector as a whole, what AOD could learn from what we were doing, because we were already so clearly already doing this work. So we've already done a consensus study with 38 GPs in Australia, where we got a consensus on what they felt were the most key ways that we could support them to translate deprescribing practice into reality, because the evidence shows that there's over 60 different evidence-based strategies we could try, but we need GPs to tell us what do you want us to try. So we now have a short list of strategies to support GPs that we're going to deliver in an implementation pilot, where we get that feedback from GPs on, well, which were actually the most effective. So as a result, we want really clear practice-based recommendations around how to translate the Maudsley deprescribing guidelines into practice based on this process of funneling down from the evidence down to the real world of what worked, to promote that with the RSCGP, as they have endorsed our research and are supporting us to communicate the findings. But the funding for this project is very minimal, so it limits how we can really capitalise on the opportunities that we've got here, because we've got the author of the Maudsley Guidelines as a collaborator on this project. We have GP collaborators from around Australia supporting it, which shows there's a real appetite and energy around supporting this work. But to do things like, for example, we would love to become CPD providers accredited through the RSCGP, which is something that is a fairly easy thing for us to do. There's a lot of resourcing required to kind of develop the content and roll that out, but that would be highly scalable. That once we've got the clear practice-based recommendations and tools that support GPs to put these guidelines into practice, we could then use the platform through the RACGP to deliver those recommendations and roll it out through.
So what is stopping you from doing that now? Is it resourcing? Or?
Absolutely.
It's just a money issue.
Yeah.
So each has been underwriting reconnections for the last 5 years, probably to the value of about $500,000 a year. Yeah. And so what you just see is the product here is, this is probably one of each's best kept secrets in terms of the programs. You can see the quality of the people and the research we've got behind it. So we just keep underwriting it, but we're just really at a point where it's not sustainable, and we think this is a problem that is shared across the sector.
Yeah.
And so it would require a small resource that could have a huge impact.
So I just want to speak actually to my committee and to chair. This is a great example of implementation science, which is not funded in the health system at all. NHMRC doesn't fund it, MRFF does not fund it. There's a huge gap for what is called health services research, which I've spoken to you guys all about with other. Thank you very much.
So one of our GP collaborators in Queensland is a professor, Catherine Wallace. She's leading an RCT to support GPs to deprescribe antidepressants. But there is that issue of implementation and working with a service, a treatment service. So they can provide recommendations to GPs around antidepressants, but they can't provide treatment for the individuals coming off the antidepressants. So they're recognising a real gap for them in Queensland, and also that piece around how do we get these sectors working a little bit more closely together.
Would you like us to have a body in Australia which is focused on implementation and health services research? I mean, the obvious example is NICE in the UK, which I think is amazing. I would love us to. Do you think that would be a good idea here in Australia?
Yeah, I mean, there's so many opportunities that a funded body to lead that sort of work would have incredible value to the actual individual that it impacts. So you've got academics and researchers with great ideas and doing wonderful research, but it stays there and it doesn't move into the world, and it doesn't often work with the services to inform the design and development. So they have the evidence, but then they realise, oh, that doesn't work for the service trying to provide it. Correct. So this is that missing piece, that because we're working with a university, we've got the robust methodology behind us, and we're the ones delivering it, so it's about real-world networking and referral pathways. So we think it's a pretty unique example of what could be happening in this space, and really positions us in a place to be leaders, both in Australia but also internationally in this area.
Is the information that you gave in that answer part of your...
Absolutely.
It is? Okay.
I'm done. Thank you.
Yeah. Jodie?
No, it's okay. Pass.
I have a couple of questions. This has been known since the 80s at least.
That's right.
Yeah.
Because I was prescribed this medication and didn't like it and just went, I'm not taking it anymore. And my GP nearly had a heart attack when I went back to him and he said, oh, well, how are you going? And I went, oh, I stopped taking that 2 weeks ago. And he just absolutely,
Yes.
I don't understand why GPs are still going to the authority scripts. Is it because we have no mental health services that people can access? So the only thing that a GP has, with all due respect to your profession, is something like this? Is it because, why are we still prescribing this? Why is your service still needed? Because your sort of addiction is completely different to anything else that we have talked about today or through this inquiry, because people are seeking help and they're being prescribed the help, and for the most part they're not abusing. They're taking the prescriptions as required. I realise that when things get awful, they have the potential to do something more, but for the most part they don't. So why is that? Why are GPs still don't have the tools to help the people they need to help with this?
If I have 10 minutes to see a patient, it's much easier for me to write a script and say, I'll see you in a month. What's much harder to do is to sit down and take a thorough history and investigation, perhaps use some motivational interviewing to take time to get to know a patient and their social circumstance. It's effort. And we are, as GPs, I don't want to pull the violin out, but there's certainly this time pressure to see patients. And I think there needs to be a cultural change. I realise that there's a philosophical question here to want to de-prescribe rather than... I mean, general practice is partly funded educationally wise through pharmaceutical education. So, of course, there's a built-in bias there. So what we're doing here is countercultural. Was an interesting question that Julian had, what sort of responsibilities are pharmaceutical companies taking? Why would they put themselves out of business? Yes.
Yeah, but they are bounded by the same ethics that the rest of our society should. Yes, I know, I get it. But there are ethics that go along with this. Just in a different committee that I was in, the one thing that came up time and time again, it was a different inquiry, was that GPs often, their breadth of experience and their education means that sometimes they'll do 6 hours on women's health, or they might not do any mental health at all. They may choose, because they're fantastic and wonderful human beings as part of our society, to get as much training as they can once they're in the doctor's surgery. But is this part of their education? would they come across this as part of their GP training, that this is something they need to be aware of? And
Not necessarily.
yeah, okay. So they have the drug companies coming in, wanting to see them, telling them this is the next best thing, and Betty will be so much better if she gets this, but not being provided an alternative for Betty. Yeah.
I think one of the particularly in the presentation around sleep issues and insomnia, which is the biggest fast track to a benzo prescription, 90% of people walk out with a prescription if they come in with insomnia, and less than 1% get that referral to access a psychological intervention. And the gold standard is psychological intervention, cognitive behavioural therapy for insomnia, CBTI. So there's obviously big evidence practice gap there. Why? It's an accessibility issue. It's the fact that it's so tricky to find skilled clinicians that provide this, but also, I guess, you know, that divide with mental health at present, how it's funded and how the wait lists for getting in to see a psychologist can be quite long, but a benzo can help you right now. And when people are presenting after having 2 hours sleep for weeks on end, obviously a GP is going to give them something, but it's part of that conversation of this is for right now. We've got to talk on the longer term, you know, what will help you long term here that's missing because there's not a clear solution for a GP beyond the prescription.
Because I can imagine for a GP, putting your patient at this risk could be a satisfying thing you want to do every day.
I think most GPs practice in a siloed manner. So most GPs are still sort of cottage. You might be in a group practice, but you're practicing without a sense of accountability. So it's the frog in the boiling pot. I don't think there's any necessarily malice, but I think that oftentimes it's in the interest of preserving a doctor-patient relationship that the main thing we take away distress. Mm-hmm. And then we can almost lose sight of the function, the reality that it's actually causing harm. Mm-hmm. And I think one of the problems is that the GPs do practice in a very isolated manner. Mm-hmm. So that there isn't, I mean, this is why we're concentrating on education and perhaps in a non-punitive or blaming way. Mm-hmm. So this is a very common problem, and that we have a different way of approaching it aside from shaming you and sort of making you feel guilty about, for example, the end stage, which is I see people when they've been admitted to hospital with a very large benzodiazepine addictions, and that's a huge problem.
So how long does it take to withdraw? So is it based on your chemical makeup? Do some people get addicted very quickly and others not so much, or what's the...
Well, I mean, certainly coming into our service, the average treatment is 13 months. This is for people that have probably been taking the medication for a number of years rather than months. And typically it is people that are on for a longer period at a higher dose that will take longer to come off, and also older adults, simply because their body's ability to metabolise and get rid of the drug from their system can take a lot longer. And they're also, as you reduce, for example, I said I worked, my oldest client was an 82-year-old woman. From the process of withdrawing her, she did have falls, she did have accidents. Her life was incredibly stressful, but she was motivated to get off the medication. It took 2 years, but she was thriving at the end of the 2 years. So it's a difficult journey because a lot of people, things get worse for periods of time, and that can feel counterintuitive. Why do I feel worse? Why am I not getting better? So it is difficult to predict how long it will take for any one person, but typically it is associated with their dose, duration of use and age.
Most of the people that you see in your service, do they have one benzodiazepine prescription, or are they on multiple?
Well, the majority would just be taking a single benzo as prescribed. Occasionally we get people who are on a couple of different ones, but they might not actually realise that they're all different benzos.
No.
So they're saying, you know, I'm taking this medication and I've got this other one, and I want to tape off this one because this one's giving me issues. And then they'll mention in the call, oh, by the way, I'm taking 2 milligrams of alprazolam as well, and not actually realise that it's a benzo, because there's a lot of there's just not a great deal of education or awareness of the problem. So, and they often come in and saying, I think I'm on a low dose because it's just one tablet of, you know, alprazolam or something like that. And it turns out that the dose they're on is actually much larger than they think, and that tapering might take a lot longer. And most of them don't recognise that they're in for 6 months, 2 years, even 5 or 6 years for some people to get off their medication.
Has there been a change in prescribing over time? So, you know, did GPs in the 80s, when this was the wonder drug, prescribe it to every second patient or every patient?
Yeah.
And do GPs now only prescribe what is necessary? Because, I mean, the other thing for GPs is in this age range, this is the age range that normally goes to a GP, that is getting to that point in their life where they actually need to be at the doctor more often.
Yeah. Yeah, I mean, certainly there has been a drop-off since the 80s and 90s when it was the silver bullet and people were prescribed and told, you know, this is the silver bullet, you'll never have to worry about anxiety again. And it really is, obviously in contrast to your experience, but for most people they take it and it's pretty, you know, within a half hour to an hour they're feeling very much better. Not your experience. So there is that kind of history that they were sold as being the solution, and certainly that's shifted, I think. And so since 80s and 90s, certainly a decline, but that's probably plateaued for quite some time now.
Okay. I will hand back to the chair. I can stop asking questions. Thank you.
I'm sure they've all done a very good job. Well, look, I am, believe it or not, actually fascinated in this discussion. I've been around a long time, and these were the sort of mother's little helpers that sung about, and many people in the 70s when I started practicing were prescribed benzodiazepines, and I'm fascinated to know that they are still being prescribed quite a lot. I think temazepam and Melgadon, is prescribed still a lot for sleep disorders, yet we already know that they can be addictive. Has that been your experience, that people are still prescribing these medications a lot for sleep?
Yeah, absolutely. And I think I mentioned earlier that we get a small pocket of funding for early intervention, and we've spent the last 3 years developing an online sleep program because we feel it is the access issue, that people don't have access to effective sleep treatments that are non-pharmacological. So we developed a step care model that aligns with the federal government's approach to mental health treatment, that, you know, population level intervention, that step one, anybody can access treatment at step one and be an early intervention, but also we now have evidence to show that our step one, which is a 1 hour online information session, is effective for people with severe insomnia. So we've got really good evidence to show that small and scalable interventions like what we're providing through our early intervention, and again I say it's funded, it's not funded, but we wanted to get the evidence to show that there are alternate treatment models available that could be available in Australia that would mean that GPs don't need to rely on these as heavily as they do.
Should we be changing our prescribing regulations?
We just asked.
Sorry.
It's like you squeeze a balloon, you restrict here, but they find it somewhere else.
I think the other part is most of our clients would say that the GP mentioned some of the harms at the first time that it was prescribed, but they'll reflect back and think they would say it doesn't feel quite like informed consent because they didn't realise how dangerous the harms would be with long-term use, that they could end up in a situation where it would take them years to withdraw, that they would be at risk of seizure, that it could be debilitating to the point that they wouldn't be able to work for multiple years. So, not to say the GPs aren't having the discussion, but I think given the severity of the harm, a lot of our clients are saying it feels like there wasn't enough warning when they were put on the medication initially.
So people aren't being informed.
Probably not to the extent, and when they're coming into an appointment, probably in quite a distressed state as well.
Okay.
Yeah. And also that sense of inherited patience, that it just gets handballed on.
Yeah.
And so there's this issue where somebody's been on it for 10, 20, 30 years and nobody knows how to start to address the issue. And there's this implicit assumption by patients, well, if my GP is not talking about it, then it's not an issue. But the GP is anticipating this person does not want to change their use. I don't want to affect our relationship by bringing that up as a challenging conversation. So it kind of sits in this place where the patient and the GP are avoiding a conversation that evidence shows if somebody starts it, it will lead to that medication being changed over time. This is why we're saying we just need to get in and provide that support and education for GPs to really confidently go in and start these conversations knowing that they will lead to productive outcomes when they're focused on improving their patients' wellbeing.
Yeah.
And a question for me, listening to all of this, so there's the education of doctors in this sector now.
Yes.
It's what about the training and education of doctors coming through around holistic mental health and wellbeing practice?
Yes.
You know, how do we treat insomnia? What are some of the techniques, you know, that are...
So there are pieces of that happening.
Yeah.
The issue is that the studies that have investigated the impacts of that show registrars going out into the world and they go with the best intentions, but essentially they start to mimic some of the habits of the clinic that they're at. So it means that the culture that they go out and operate within starts to slowly change things. So that's probably, it's a necessary part of this picture, but that's the long game. We need something right now to change prescribing behaviour right now, establish prescribing behaviours.
But you're the only group in Australia that's doing this.
Yes.
And they're about to lose their funding.
And your funding is through the
State
state.
government, Victorian state.
Okay. You can't use standard Medicare-based funding.
The treatment takes quite a, we're working with probably some of the most pointy end of clients, but many of them take many years of treatment and they're getting support on a weekly to fortnightly basis. Most of it, a lot of the people that we work with have complex trauma and that's one of the reasons why they end up on a benzo. So they need quite a lot of psychological support. They get peer support, telephone support. So it would be pretty tricky to translate it across the 10 sessions and just off you go.
So you need block funding. And is it your view, just one last thing, whether, you know, the SSRI drugs are going to be a similar thing in the future?
Yes, and SNRIs, I
SNRIs
think, are even more
particularly.
concerning. Yeah.
Difficult withdrawal.
Absolutely. There's really a bit of momentum growing in this space that the RACGP and the Pharmaceutical Society of Australia are endorsing these Maudsley deprescribing guidelines. We know that one of the agendas of the Quality Use of Medicines Alliance in Australia is antidepressants, that is kind of the next big target. But we're saying let's address the issue that we've wanted to for so long with GPs, I guess, and then replicate this with antidepressants. We've already got almost 40 years of experience behind us. We know what we're doing. We've changed our approach over an extended period of time that responds really well to the needs of our consumers. It's just about how do we work with primary care to see this delivered across there.
Fair enough. Thank you. Any other questions?
Do the GPs, just one, do the GPs actually have tools outside benzodiazepines to assist these patients?
They're accessible, but you need to be aware that it's a problem. And I think one of the issues is that you can be accustomed to just that weekly or that monthly consultation, and it doesn't seem to be a problem until there's a fall or something bad happens. So I think our goal is to bring it into awareness. Bear in mind that not everyone will be a candidate for deprescribing, but we certainly could be doing better than what we're doing now.
Thank you so much. Really interesting evidence. I'm sorry that I had to jump out for a little while. And thank you for coming along today. If you've been asked to provide any additional information, could you please forward it to the Secretariat by no later than Monday, the 11th of November 2024. You'll be sent a transcript of your evidence and will have an opportunity to request corrections to any transcription errors. And once again, thank you for coming along today.
Thank you for having us.
Thank you.
Thank you very much.
And I will now suspend, shall I? Public hearing held at Mantra and Russell of the House Standing Committee on Health, Aged Care and Sport for the inquiry into health impacts of alcohol and other drugs in Australia. In accordance with the committee's resolution of 4th of August 2022, this hearing will be broadcast on the Parliament's website, and the proof and official transcripts of the proceedings will be published on the Parliament's website. I now welcome Adjunct Associate Professor Leanne Bose, CEO of the Australian College of Nurse Practitioners, to give evidence. For the Hansard record, would you please state your name and the capacity in which you appear before the committee? This hearing is a legal proceeding of the Parliament. The giving of false or misleading evidence is a serious matter and may be regarded as contempt of the Parliament. The evidence given today will be recorded by Hansard and attracts parliamentary privilege. I now invite you to make a short opening statement before we proceed to discussion, and thank you very much for coming along today.
Thank you for inviting us to speak. So I'm Adjunct Associate Professor Leanne Bose. I'm the CEO of the Australian College of Nurse Practitioners, and I am a nurse practitioner practising in primary care. So thank you very much. You received our submission where we addressed a number of issues, but I thought I'd take the opportunity to comment a little bit further. Nurse practitioners work across all different sectors of health, and we're very active in working in areas where there's commonly stigma associated with different types of conditions, and great examples of those are nurse practitioners working in the areas of mental health, addiction and substance misuse, bloodborne viruses, other areas of practice where there's often stigma associated. Part of the reason for that is a lot of people feel safe talking to a nurse. A lot of the time we're the ones that they disclose issues to. So it's been one of those areas that a lot of nurse practitioners do move into. Nurse practitioners are advanced nurses that are trained with a generalist scope of practice, and then upon that they can build advanced practice skills and apply for endorsement as a nurse practitioner. But a lot of them specialise in different areas of practice, either before or after becoming nurse practitioners. So a lot of nurse practitioners in Australia do specialise in the management of substance abuse, substance misuse, addiction and mental health. Often both. And one of the things I really wanted to talk about was some of the problems that we have in Australia, very much centred around the fact that anybody with an addiction issue, by very nature, should be considered as somebody with a dual diagnosis. We should not see patients as addiction patients. We should see people with addiction problems that are often, more often than not, and I don't think in my practice I've ever seen anyone that doesn't have a mental health issue as well. And this is part of the problem with the poor outcomes that we see from addiction management and addiction treatments in Australia is we poorly recognise and treat mental health problems that go along with it. We also have a very condition-centric model of healthcare. So someone comes in and they're not seen so much as a person, they're seen as someone with a problem. And we focus very much on that problem. And as we know, people with addiction, they struggle with day-to-day life a lot of the time. They have mental health problems as well, self-care neglect, often poor social connections and additional socioeconomic burdens. However, what we do is we focus on their addiction or their substance misuse rather than looking at the whole person and the broader effects. And of course, when we have someone with such complex issues to deal with, we don't often look at them from the perspective of what chronic diseases there might be, what risks there are for chronic disease, and we don't capitalise on preventative healthcare opportunities very well for this group of people. So essentially what I'm saying is we need person-centred care, not problem-centred care. Another problem is too the pressure, particularly in primary care, which is the entry point for people, the pressure under some sectors of primary care to do rapid, short consultations, doesn't allow people to develop the relationships where they're comfortable to disclose or discuss these types of problems. Often that's made a lot worse by the perception that there'll be stigma associated. A really good example of how we are failing in the health system is in relation to bloodborne viruses, which is another related issue. Even though we now have a cure for hepatitis C, we're still seeing very low rates of detection and low rates of treatment in Australia, which is a real blight on our health system. It's really bad. It's demonstrating where we're failing. These treatments are now accessible, affordable and successful and very well tolerated, yet we still have very high rates of failure to diagnose and not treating people. So we're less likely than we should be to screen for bloodborne viruses, but also chronic disease more generally. We know the effects of alcohol and other drugs on health impact on many different body systems, many different chronic diseases, yet we're still not screening people appropriately for chronic disease.
I might get you just to
Yep.
stop there, perhaps, and we'll start with questions. Michelle, do you want to start?
Look, I think the role for nurse practitioners can't be overstated in this space, given that we have such dire workforce shortages amongst psychiatrists as well as addiction medicine specialists. How do you see us encouraging more nurses to take this up as a career?
There's a lot of work already happening to support those more experienced nurses in our system to consider becoming nurse practitioners. There's a few issues still within the system. Of course, we're working very hard on all of them, but we still do have some blockages in the system. It's still not a role that works particularly well in primary care, and you would know of all the work that's been going on with the scope of practice review and the multiple Medicare reviews that are happening as well. And there's also the nurse practitioner workforce plan. Now, there are some changes that have come about from some of those reviews, and there's certainly quite a lot more on the way, which is increasing confidence in our most advanced nurses in our system currently to go ahead and do the training and complete the remainder of the requirements. It's not simply a matter of doing a course. There's a number of other requirements to become a nurse practitioner, but it is increasing the confidence. We are seeing increasing enrolment rates, and we also have scholarship programs available now. So while I am known for focusing on the blockages and the problems, there's certainly an increase in interest and an increase in confidence for nurses to become nurse practitioners. There are a couple of significant issues, though, in primary care that make it very difficult for us.
Can you elaborate on those?
Well, the biggest one probably, and as I've said, and you'll probably pick up, I'm quite passionate about this, the dual diagnosis. We are unable to refer to psychologists under Medicare. So what that means is if I refer someone to a psychologist, they don't get any Medicare rebate on their consultation. So that is a significant block. When a person chooses to see a nurse practitioner and they make a choice to disclose some of these issues to a nurse practitioner, to then have to face disclosing to a second person to get a referral is quite challenging for them. I've actually had some really significant disclosures in my consulting room, and I do talk to other nurse practitioners who've experienced the same. And unless they can afford to pay fully for psychological psychological treatment, they have to go and disclose to somebody else. And as one patient said to me once, "But Leanne, if I wanted to talk to my regular GP about this, I would have done it already. But I feel like I can talk to you, and I felt comfortable to talk to you, and that was my choice. I don't want to repeat myself again. I don't feel safe." And that's not any, that was no problem with the GP. She had a great GP. She just didn't feel that she had that relationship. And I understand that. We all feel differently about different health professionals. And I think at the end of the day, though, it is about choice as well. And
So that's a very simple thing that we can change. This inability to refer to a psychologist is a simple stroke of the pen type thing. Is there any other thing?
It's actually pretty hard. So currently all referrals to allied health across the board are through GPs only. So it's actually really hard to change that because it's exclusive to GPs and they are, I guess, actively campaigning against anybody else having the ability to refer to allied health. It's also tied in very much with our current Medicare system, practice accreditation and incentive programs. So while I'd love to sit here and say, yes, go and get it changed, I also acknowledge it's incredibly complex. It is challenging for some people to think about addressing that issue and opening that up to other health professions. That's just being very plain.
Thank you.
I just want to acknowledge your passion
Yes,
and commitment.
there's
to
a lot
this.
here.
Yeah.
If only you knew.
Have we got sufficient nurse practitioners in the community at this stage? I know you're saying we've got more people taking up. Have we got sufficient?
No, we don't. But we do have more than what we're using. There's we estimate 30 to 35% of nurse practitioners currently working in other jobs. They're not working as nurse practitioners because the primary care system's really challenging to work in, and a lot of them are rural and remote, or they're in underserved communities, and the only model they can work under really is the primary care model. And because there's challenges with that, which are very complex, they're not able to work and to make it work as a nurse practitioner, so they're working in other roles. They might be working in a hospital as an RN, or they might be, working as a practice nurse instead of as a nurse practitioner. So we're underutilising the workforce we have. So we actually do have a number of nurse practitioners that could be enabled while we continue to work on the pipeline of nurse practitioners, which is increasing.
What do you think are the reasons for people engaging more with nurse practitioners than, say, a doctor?
It depends very much on the health professional. Like my GP, I can sit and have a great long conversation with, and that's never an issue. But it depends on their access to services. It's not so much about the GP, it's more about perhaps the clinic or the model that they're working under. A lot of, like my demographic area where I practice, it's all rapid turnover clinics, and it's see a different GP every time you come in because it's whoever's on that day, and you get 10 minutes and one problem. We see a bit of that, and I think a lot of the health reform we're working on at the moment will hopefully support those businesses and GPs to move out of that model a little bit, but I'm not under any illusion there's a quick fix for this. There's still a lot of GPs out there that do spend time. The difference, I guess, with nurses is we take a very person-centred approach from the beginning, and we do spend an awful lot of time with people, which can actually give them the confidence to open up. And there's a bit of a perception, I guess it's something that's been around for a very long time, that nurses are not likely to judge you or apply any discrimination, but I would say it's the same across other health professions as well. It's just the perception of the public. Yeah, I'm not suggesting that other health professions do judge. I'm just saying it's just a perception. There's a lot of trust there.
So as in your role, what would you recommend that we need to consider if we're going to address the impact of alcohol and drug through your lens?
So I'd like to change a lot of things. I'd like to change the focus from addiction to dual diagnosis. I'd like to focus a lot more on trauma-informed care as well. There's often a lot of trauma involved. I'd like to enable health professionals to work to their full abilities, whether it's a doctor or a nurse practitioner or anybody else. I think we have a great deal of professional judgment, as do psychologists, for example, and I do have concerns that through our funding system we take a lot of that professional judgment away. For instance, if a GP refers to a psychologist, it's for a set number of visits, and the psychologist has no say in whether that person needs 2, 6, 10 or 15 visits for the year. It's very much controlled by the funding system, and I'd like to see professional judgment to be more considered and to be used more as a guide for care, because I feel like not every person's different, but I think through our funding mechanism we're expecting them to be the same as each other. And these are big things, not easy to change. I acknowledge that, and if you want my wish list to be very, very long, but I'd like to use my professional judgment to determine that somebody needs to see a psychologist, and whether that's urgent or not urgent, and whether they, need financial assistance to see that psychologist. And then I would like to be able to rely on that psychologist's opinion along with my own professional judgment and involve the patient's GP to determine whether they need more visits or not, rather than being told you get this many and that's it, because that doesn't fit everybody.
Well, the Medicare model is a transactional model. That's how
correct.
It was designed.
Yeah.
What you're asking for, and I think most of us would certainly support, is a chronic disease management plan.
Yeah.
Basically.
Yeah.
And I think the system is very, very slowly, very, very slowly moving towards that.
Yep.
Sorry, I didn't mean to interrupt.
No, that's fine. It's all good.
Any questions? Any other questions? No? I just want to get down to sort of a granular way that you work. How do you get paid for what you do?
So patients, for me personally, when I see patients, they pay me.
Do you get any Medicare?
They do get Medicare rebates, yes.
What proportion of what you charge would that rebate cover?
Me personally, I'm different to everybody else. I work full-time for the ACMP and I see patients on Saturdays just to provide a community service.
Right.
So I tend to bulk bill most of my patients.
Right.
Which means the average consultation pays about $26.
And how long would you spend in them?
Around 20 minutes. Yeah.
Okay.
Yeah.
So about $50 an hour roughly?
Probably, yeah, by the time you do your documentation and so forth, yeah.
Yeah.
So a lot of nurse practitioners have to charge private fees. I do charge private fees for new patients because I book them in for an hour.
Right.
And the rebate's only for an hour about $70.
Right.
So I do charge them private fee because by the time I spend an hour with them and then 20 minutes documenting everything and writing, because I always write a letter to the GP or anybody else involved in their care, by the time you do all of that, it's an hour and a half, yeah.
Would it be possible for a nurse practitioner to work in a multidisciplinary practice?
Absolutely, it's possible. I've owned one. I've owned GP clinics. I currently work in an NP clinic that I own. Absolutely possible.
What clinic that you own, sorry?
I own Craigieburn Specialist Consulting Suites. I used to own GP clinic. I've built them and employed GPs, nurse practitioners, allied health. So it can work, but it's financially not viable to have nurse practitioners in your clinic.
At the present time?
At the present time. They just raised the rebates 30%, which helped a little bit.
Right.
Yeah.
But it is possible to run that sort of...
It can work from a workflow point of view, from a professional point of view. It can absolutely work. And to be honest, GPs are always seeking out nurse practitioners to come and work with them in their clinics. Just as they would look for another GP, they look for a nurse practitioner to help with the caseload, with the patients coming through the door, and they see the positives. Most of them really do see the positives, but when they crunch the numbers and they look at what the nurse practitioner can bill, and then they look at taking the admin fee to keep the practice running, it doesn't work for them financially, so they generally end up pulling out.
But let me put this to you. Is an ideal system a multidisciplinary clinic that is financially viable, that would see a patient with drug and alcohol problem and mental health problem, is that the best way to do it? A multidisciplinary clinic?
I'd love to say it was. It's a great way to do it, but the way we are in Australia, we also have to find ways to support smaller practices, because not every community has the need for or can support a large multidisciplinary practice. So I've been very strongly advocating for that multidisciplinary model, but also acknowledging supporting smaller practices. For instance, there's a nurse practitioner clinic in the Mallee in Victoria. She services a huge community. So I also am very strongly advocating that nurse practitioners can and should be supported to continue offering those kinds of services, and in the hope that one day that practice will attract other types of health practitioners as it grows. But we can't only have nurse practitioners working in multidisciplinary practices, because not every community can sustain one.
Sure.
Yeah, so we're down a bit of a slippery slope if we're talking about only multidisciplinary care. Ideally, it would be great if we could have it everywhere, but it's just not going to work. And the other thing about that is multidisciplinary care doesn't have to be under one roof. I refer to specialists across Melbourne, GPs across Melbourne. I have patients come to me from all over Victoria. I've got a bit of a reputation over the years for helping people, but you know, I collaborate with people around the state, sometimes even interstate, where specialists are involved in their care. So multidisciplinary care can very much happen when we're not under the same roof, and we should be encouraged to find ways to do that and to keep connected with other healthcare professionals that are not under the same roof. And digital health's a great way of doing that. But as I'm often fond of saying, digital health relies on all health professionals in the team being fully engaged with it. And unfortunately, you know, only some of us are at this stage, and we really need to work on that.
Good. How do we get better drug and alcohol services to communities?
It's a very good question, and it is very much a multidisciplinary approach. I think streamlining referral pathways is one way, so that people don't have to jump through so many hoops to get connected with services. I think to some extent too, one great way of improving access is to allow self-referral. But because we've got that issue with Medicare funding requiring a referral for some services, it sort of stops that self-referral, because often it's that stigma and that perception. Whereas if I can go straight to that specialist level care who's used to dealing with these issues and does so without discriminating, you know, it's a perception. Very few health professionals ever do actually discriminate, but it's the patient's perception of what they might experience and their fears. So if they can self-refer into key services where they can go in and talk to somebody in what they see as a safer space, then I think that would help significantly.
Because it's not just about providing inpatient services.
No, and look, I'm also have been looking into inpatient services, and I've spent quite a bit of time looking at private addiction and mental health as well, and how we do or don't do things in that sector. And one of the things I'm working on too is getting nurse practitioners able to practice in private hospitals, because currently we can't. Private health insurers want to pay for nurse practitioner services in private hospitals because they know that we will go in and see the person, do chronic disease management, as well as treating what they've been admitted for or assisting the treatment team with that. But we're just dealing with, trying to make some changes in the legislation to make that possible. But private health insurers are very keen because they can see the added value, particularly in the mental health and addiction space, but across the board in private health. But I think one of the biggest failings I'm seeing in private hospital sector, is a failure to acknowledge dual diagnosis, and that they're admitted for a problem, they're not admitted as a person, and I think we're missing.
Well, they're actually similar funding issues.
They do, yes. So, you know, we're missing chronic disease management opportunities, we're missing preventative health screening opportunities because these people, a lot of these people are struggling to access health services because they feel the stigma, and they often haven't had, you know, good connections with health services. They haven't had regular health checks. There's a lot of self-care issues as well, self-neglect, and I think, you know, anybody admitted anywhere should actually have that opportunity to have their health assessed. Medical and mental health are not disconnected. Physical and mental, I mean, are not disconnected. They're actually very intricately connected. And I think we miss a lot of opportunities in the private and public sectors.
Good. Thank you. I don't have any further questions. Any further questions?
One question. We are rolling out Medicare mental health clinics around the country, and they're a good example of multidisciplinary care. We don't have enough psychiatrists, obviously we never will, but nurses we could absolutely scale up. What are your thoughts on, for example, having specialist nurse practitioners in those clinics assisting with AOD issues alongside the other mental health workers?
I think that'd be fantastic, because nurse practitioners can also work closely with psychiatrists, and they can prescribe the medications often required. I have great examples of psychiatrists, even in Melbourne, that work with a network of nurse practitioners. They work very much as a team, but not under one roof. So always liaising. A nurse practitioner knows which patients to escalate to the psychiatrist, but can handle many of them independently, and they work as teams. And that's a really great model. So it's about thinking outside the box. And if you have a psychiatrist that can work across these services, and then have nurse practitioners connected with the psychiatrist, and have that relationship develop of trust where the nurse practitioner knows which patients to escalate, the psychiatrist is confident that the nurse practitioner will pick those up, and they have case conferencing and things like that, and regular meetings. It works really, really well. And that way you don't need a psychiatrist for everyone, but that you're still connected with one. And that works really well. The only issue is if you still require a referral for a psychologist, a nurse practitioner won't be able to do it. The patient will get disconnected from that system. So you would need a GP available to be able to write the referrals. Yeah.
Good.
But if you could fix that, that'd be great.
Yeah, well, we can.
I don't ask much.
We don't have any further questions, but thank you very much for your
you.
evidence today. It's been really interesting. If you've been asked to provide any additional information, please forward it to the Secretariat by no later than Monday, the 11th of November 2024. You'll be sent a transcript of your evidence, and we'll have an opportunity to request any corrections to transcription errors. And once again, thanks for appearing.
Thank you, and I'd be very happy if anyone's got any further questions to take them and respond.
Great, thank you.
Thanks so much, and look, thanks so much for focusing on this. We tell I'm a little bit invested.
You're very passionate about it. Good.
An important topic to be invested.
We'll now conclude the public hearing, because we don't include the site. I'd like to thank committee members and witnesses for their time today and declare this public hearing closed.